Welcome, everyone. Thank you for joining us today for the International Myeloma Foundation's New England Virtual Regional Community Workshop. So before we get started, we want to make sure you understand the importance of your voice. Your voice always matters. So this is a link to a survey, and we ask that you please click on that link. So at the end of the meeting, you'll be able to let us know how you felt this was for you. Was it informative, helpful, understandable, something that you can go back and have better conversations with your healthcare team on? We'd also like to thank our sponsors, and tonight they are AbbVie, Amgen, Bristol Myers Squibb, GSK, Johnson & Johnson, Karyopharm Therapeutics, Sanofi, and Takeda. So this is our agenda for today. And no, I am not Dr. Joseph Mikhael. I am Robin Toohey, and I'm Vice President Patient Support at the International Myeloma Foundation. And the rest of this program is correct and accurate. We're going to try to stay on time here. And we just want you to see where there will be breaks and opportunities for questions with the panel. We want to give you a nice reminder that the info line is available to you, and that number is right up there, 1-800-452-CURE. That's a great phone number, right? And then infoline@myeloma.org. You can email them. And this is Paul and Missy and Teresa, and they are so kind, compassionate, knowledgeable, and happy to talk with you and help you to find the resources that you need. These are some of the IMF educational publications, the ones here where you see stars. These are brand new or updated publications, and these are also available on the IMF website, so you can read them online, or you can call the info line and ask them to send you the actual physical publication, however you prefer to read them. This is the IMF support group team, and I'm very proud of this team. We have Becky and Jen, myself, Nancy, and Cecilia, and we work with about 160 support groups across the country. If there's not a group near you, please contact us, and we're happy to help you start a new group or to find the group that's in your area. We also have, in addition to the physical groups that have locations on that map that we just saw, we have these groups that are called special interest groups, and these are always virtual, and these are meant for everyone and anyone who has something in particular that is maybe a little bit more unique that might not get talked about at the local support group. So you can see here we've got Las Voces de Myeloma, which is a Spanish-speaking group, Care Partners Only group, who actually meet Thursday night this week, so that one's coming up. Smolder Boulder. Families, that's for patients and care partners who have young children. They definitely have some other challenges to talk about. High-risk myeloma and living solo and strong if you do not have a care partner. And we talked about the IMF's info line, but what is this AI chatbot all about? Who is Milo and what is Milo? So Milo is a way for you 24/7 to ask your questions, to have the best answers. It is an AI-powered chatbot, but it's a chatbot that has empathetic support. It really listens. It's a kind chatbot, and it can give you information 24/7. So if you're up late on decks and you have a question at 2 a.m., you can click on Milo and ask your question. Spark Cures is another amazing company that we very recently partnered with, and they are very helpful in finding clinical trials through a search engine. They have personalized trial matching for you, and they also have educational resources on clinical trials. And, clinical trials are our friends. They are therapies that are the latest and greatest, not FDA approved yet, but definitely something that everyone should be considering and talking to your healthcare team about. So it's my absolute pleasure now to really get this meeting started. And of course, today we have Dr. Joseph Mikhael talking about Myeloma 101.
Well, thanks so much, Robin. Always a pleasure to join the stage with you and with my good friend Kevin. So thanks, Kevin. I know you'll get more of an introduction in a couple minutes. I also want to apologize to the crowd that it's kind of the Dr. Joe and Kevin show. At least the Kevin show part of it is good, but you're hearing a lot of me tonight. We've just sadly last minute had to make a little switch with a speaker who's now unable to join us. But for those of you from the Dana-Farber area, you know Dr. Monique Hartley-Brown. She's fantastic, and we are very grateful to have her as part of the IMF family. And just with some unfortunate travel plans changing, Dr. Dr. Hartley-Brown's not able to join us tonight. So I'm the sub-in for a couple of the talks later, but as it stands now, we'll dive into Myeloma 101, because one of the things I think is really important when we have a workshop like this is not only to give you the latest and greatest, which we're going to get into, but also just to remind us of the foundation of myeloma and what the basics are. For those of you who may be joining us that are relatively new to the myeloma community, we want to welcome you and make sure that you understand the disease. As we've always said for many years, knowledge is power, and we're here to empower you for your journey with myeloma. But also for those of you who are veterans, if you will, to myeloma, and you might think that you're the experts, and that's great that you are, it never hurts to get back to these basics so that we can not only understand them better for ourselves, but able to share it with others. And very often in the role that you have, whether it's teaching your family or your friends or your support group, you can often be involved in the education of individuals. So I'm just going to quickly review the basics of blood and cancer, talk about the key terms of myeloma. I'll be a bit brief on the staging and classification because sometimes that's a little bit artificial. And then we'll talk a little bit about our approach to therapy, although we're going to be diving into that a little bit more when I talk a little later about frontline therapy and relapse therapy. And then I'd like to talk a little bit about disparities because there really are such an important part of multiple myeloma and how we care for our patients. So I always go back to the basics, right? So remember, I'm a hematologist, so I'm a bit of a nerd. I'm a little bit obsessed with blood, although thankfully my wife likes that I'm a nerd, so that's good. And we love blood, right? And I always say to my other colleagues, like, what use is any other organ without blood? We need blood for the heart. We need blood for the kidney. We need blood for the liver. We need blood for the lungs. And so when you think of blood, it originates in the factory of our blood that we call the bone marrow. And when we look at blood, it's really made up of two bits. There's the liquid bit and there's the solid bit. And the liquid bit we sometimes call the plasma. The solid bit is primarily three kinds of cells. And for those of you who may be wine connoisseurs in the New England area or wherever else you're joining us from, there may be a few people from Napa that have secretly joined in on the registration here, which we're happy for. I always think of it like wine. There's red, there's white, and there's rosé. So there are red cells. Red cells are little red trucks, as it were, that carry oxygen throughout the body. They pick up oxygen from the lungs, they go deliver them to the tissues, and they come back for more. And that's all that red cells do, constantly circulating, pick up, drop off, pick up, drop off. White cells are a lot more complicated. And Kevin will also be talking a bit about white cells a little bit later when we think about our immune systems and so on. But white cells really are kind of like an army that makes up our immune system, or really, you can think of it, we have 5 major branches, at least of the military. I know there are other branches, but 5 major branches, as it were, and we have 5 kinds of white cells, to be honest, in our body as well. So we can think of them as protecting us. And then thirdly, the rosé cells, they're not really rosé cells, but I call them that, are called platelets, and these are just little cells, kind of like the ambulance. They get there first if we have a cut to help start the clotting process, and they make a phone call to something called factors that really form a blood clot. So that's hematology in a nutshell, and hopefully that'll help us as we launch in to think a little bit about multiple myeloma, because multiple myeloma is a cancer that originates in that factory of the blood, in the bone marrow. And when I go to a factory, I see not only what comes out of the factory, the red, white, and the rosé, I see all the things that make those cells. And there's one very small part of the factory that are called plasma cells. And these cells are really important. They're kind of a part of that white cell system, part of that immune system, that help us fight off infections by making what we call antibodies. So if, Kevin, I know, is busy in his clinical practice, and I'm going to get the privilege of seeing Kevin in person, in the flesh later this week in Richmond, Virginia, I know that as he cares for patients, one of the things that he wants to make sure he does is every fall he gets his flu shot. And getting that flu shot is really important because it's going to protect him and indeed his family and patients and others from the flu. But what happens when you get a flu shot? When you get a flu shot, that message gets sent to your plasma cells in your bone marrow. And your plasma cells make what we call antibodies to fight off the flu. The same thing happens with COVID, with measles, mumps, rubella, so many things we get exposed to in life. We use our plasma cells every day. Myeloma, sadly, is a cancer of those plasma cells, whereby those cells now are not making good antibodies that help you fight off infection, but they become what we call malignant or cancerous, where they now can, unfortunately, produce a bad antibody. Sometimes we call it an M or a monoclonal, as opposed to normal antibodies that are called polyclonal. And these proteins, or antibodies as we call them, they can go and attack the kidneys, the bones, and other parts of the body. We always want to make that distinction because sometimes the word gets mixed up. It's myeloma, not melanoma, of course, which is a type of skin cancer. And so myeloma is really not that common. Obviously, for this community, it's a skewed community because we know about it, but it's about 2% of all cancers. It's most commonly diagnosed between about 65 and 75. The average age is about 69, although, as I'm going to share with you in a moment, it is younger in those of us of African descent like myself, or those of our Hispanic American population are diagnosed about 4 to 5 years younger than that. And we kind of classify a little bit of myeloma based on that type of antibody. And in fact, the immune system is so complicated. Instead of having just one kind of antibody, we have all sorts of types. And as you all know, we as doctors and as nurse practitioners and other healthcare providers, we love to use words that patients don't understand. So we don't really call them antibodies, we call them immunoglobulins, which is just a big way of saying immune or immuno. Globulin is an old word for protein. They're just immune proteins. And so we have immunoglobulin G, immunoglobulin A, immunoglobulin M, immunoglobulin D, and immunoglobulin E. And I'll show you a little bit more detail about that in just a minute. So as I mentioned, it's about 2% of all cancers, which means last year we saw about 35,000 new cases of myeloma across the US, and tragically about 13,000 deaths. That being said, we know that we're making huge improvements in myeloma. I've been a myeloma doctor for over 20 years. I have never seen the advances as we've seen literally in the last 2 years. So although we consider myeloma incurable, I always say we haven't cured high blood pressure or diabetes either. We try to control it over the long term. I'm very confident in saying, as I saw new patients today in my clinic, that I expect the vast majority of my new myeloma patients to live more than 10 years, and hopefully for that many of them even longer. As we'll get into at the end of my talk, myeloma is much more common in those of us of African descent. It's twice as common. And we sadly know there's a higher mortality in that group of individuals, meaning a Black man or a Black woman diagnosed today is expected to live only half as long as the same aged white man or white woman, although we know that is changing. And we at the IMF are trying to be a part of that. So going back to those immunoglobulins for a moment, we have the big Y-shaped immunoglobulin or antibody, as you see in the picture there. But interestingly, if you look carefully at that Y, there's the big long pieces, but there's a couple of small bits on the end, and we call those light chains. And interestingly, almost 20% of myeloma patients, we don't find the whole immunoglobulin or big protein. We find just the little ones on the side, what we call light chain. And then even more complicated, there is a group of patients that are what we call non-secretory, meaning the plasma cells are growing in the bone marrow, but they don't make that antibody. They can still cause a lot of damage by the way they mess with our whole immune system, but they don't have that. Thankfully, that's a small group of patients. I had a patient in my clinic today who has non-secretory myeloma, and it's challenging because we can't so easily follow the lab work that we have. The majority of patients have what we call the IgG version or the IgG multiple myeloma. As I mentioned, about 20% of them have light chain myeloma. So for those who are really interested, this is what we look at in the lab. And I know to most of you, this is like, what is this weird picture that Dr. Joe is showing me? But back to my nerd ways, this is what we do in the lab. And this is a beautiful picture to me. I mean, this is like, I should have this framed and up on the mantle above the fireplace. I'm not sure my wife would go for that. But this is basically what your proteins in your blood look like. There's the big mountain peak at the start. That's a good protein in your blood called albumin. And then you have all these little miniature, like what I call Scottsdale Hills, because I live here in Scottsdale, Arizona. We got these nice little hills. And if you look down on the right, we can characterize them into those categories we saw before, G, A, and M. And then there's those light chains. There's two kinds of light chains, something called kappa and called lambda. So why am I showing you this picture? I'm showing this picture because on the next slide, I'm going to show you what happens in myeloma, because this is the normal situation, but this is what happens in myeloma, where all of a sudden we find in the lab this really tight band, as we call it, or M spike of bad protein. And that's why you might hear people referring to their myeloma. What is your M spike? How high is the M spike? And in this case, we know it's an IgG type because you can look down below and see how dark the band is next to the letter G, and down at the bottom of between the kappa and lambda, because with myeloma, it's always one of those two. In this case, it happens to be lambda. So this is a patient who has an IgG lambda multiple myeloma. And so when we measure myeloma, we can measure the plasma cells in the bone marrow, but also from just the simple blood tests, we can measure those heavy chains or the whole immunoglobulin level, the M spike as it were, or we can measure those light chains as well. Now, it's really important to know that myeloma has a huge spectrum. So this is one of the most unusual features of myeloma, that on the one hand, it's a relatively rare cancer, as we've said, 2% of all cancers. That's what's in the red on the right here, the active myeloma. But interestingly, we have two so-called precursor or pre-malignant conditions, something called MGUS, or monoclonal gammopathy of undetermined significance. It's a big mouthful, and something in the middle called smoldering myeloma. MGUS just means that someone has a little bit of that abnormal monoclonal protein. Those immunoglobulins are not right, but it's such a small amount, it doesn't by itself really mean anything, and we typically don't treat that. It's kind of like saying, I don't know, someone's got several moles on their body. They're not all going to become skin cancer. Hopefully none of them will, but they have that potential. And so when someone has MGUS, which interestingly occurs in about 5% of everyone over the age of 40. So it's incredibly common to have the precursor, but uncommon to get the actual myeloma. And then in between, there's something called smoldering multiple myeloma that I'll talk a little bit more about when I come to newly diagnosed myeloma later. One of the challenges is that the diagnosis of myeloma is difficult to make because people present with very generic things. They're tired, they have bone pain. If a blood test is done, they have the low red blood cell count. Remember the red, white, and rosé? They have what we call anemia. You know, if I'm a primary care doctor in the community, I see this every day. So it's sometimes hard to distinguish this from other common things, but that's typically how people start to be diagnosed with multiple myeloma. But to truly have myeloma, it's more than just fatigue, it's more than just pain. You really have one of these typical crab criteria, as we call it, meaning the calcium level in the blood is high, typically because the bones are getting eaten away. There's renal or kidney damage. There's anemia or that low red blood cell count, or there's some kind of bone disease, which sometimes can just be a bit of a thinning of the bone, and sometimes it actually is a real fracture. A few years ago, we added 3 more features to them. These are sort of more biochemical features that I don't need to go into a lot of detail, but why we now sometimes instead of saying what are the crab criteria of myeloma, we call it the slim crab criteria, which just means that if by definition, myeloma means you have more than 10% of those plasma cells in your bone marrow. Normal is less than 5%. But if it's over 60%, even if you don't have those crab criteria, we know that it's growing and we need to do something about it. If someone's light chain levels are very high, what we call involved over uninvolved, or if when we do an MRI of their bone marrow, we see more than one focal lesion. Normally, bone marrow should be very diffuse, as we call it, or homogeneous, looks like just a very monotonous picture. But if we start seeing little areas of growth, it tells us that the myeloma is growing. So when we think about these crab symptoms, what does that mean for a patient? It may mean that they're very tired. It may mean that they're weak. They're going to have bone pain. Sometimes even just this tumor, this myeloma growing in the system makes people lose their appetite. They can lose weight. Although there are some patients that really present with no symptoms. And that's one of the reasons why we're exploring this whole idea of maybe even screening for multiple myeloma. And so lots of things to learn in our labs here. I see that there's lots of detail here, but I will walk through this with you very quickly, that we do those basic blood tests that are listed up at the top, and then we do the blood tests that are specific to multiple myeloma. So I won't go through this in a lot of detail because we'll get to some of this when we talk about other areas, but it's important that, as we always say, the blood tests that we follow in myeloma are not the typical tests you just get with your routine physical exams, that very often we have to do more sophisticated testing. I've tried to simplify this a little bit more on this next page, where we have the basic blood tests looking for the red, white, and the rosé, and those chemistry things like the kidney function and the like. And then we do those very specific blood tests for myeloma. So for most myeloma patients, we're following pretty much one of two important things: that M spike, if you're the type that has M spike, or the light chain level, if you have light chains. In a small proportion of patients, we can actually only detect it in the urine. And so sometimes we have to measure it in the urine as well, but typically we measure it in the blood. One other area of diagnosis, before I talk a little bit about treatment and wrap us up here, is that when we test for myeloma, the old days we used to do plain x-rays, what was called the skeletal survey, or shout out to any of my Canadian peeps who might be here tonight. We used to call it the skeletal survey, which are good tests back then, but we've learned that they're not very sensitive, meaning there has to be a lot of damage to the bone before a simple x-ray will detect a change. So now we tend to do more sophisticated imaging, like CT scans and MRI scans, which detects the change in the myeloma. Because what happens is either the plasma cells that directly go and invade the bone, or sometimes they just mess with our metabolism. They mess with the normal way that we make and break down bones, and it causes the bones to break down more quickly. And lastly, of course, the test that no one really likes to talk about because it's not the most comfortable thing in the world, but myeloma is a cancer of the plasma cells. The plasma cells live in the bone marrow. So if we want to understand the cancer, we got to get to the bone marrow. So we are working on lots of ways to reduce the number of bone marrows that people have. And I'm sure this is going to be one of the questions we get today. How are we doing with detecting myeloma in just a peripheral blood test instead of a bone marrow? But ultimately, and at least initially, we always have to do a bone marrow test to confirm myeloma, because that's where we find that greater than 10% plasma cells. But interestingly, we don't just look at the sheer number of cells, we look at the genetics of those cells. Now, these aren't the genes that you pass on to your children. These are the genes of the tumor cells themselves. And we can look at different things that gives us insight into the different kinds of genetics. I think the slides got switched on me here, so I'm gonna make a little change here. So as we now have made the diagnosis of myeloma, it's really important for us to look at how do we treat it. And I'm going to get into this when we talk about the initial treatment of myeloma, but generally speaking, we divide people into two categories. Are they eligible or not eligible for a transplant? And we'll talk a little bit more about that as we go. But what I really wanted to focus on in this slide was, it's not about showing up to a doctor's office and a doctor saying, this is what you take, you'll take it and you'll like it. It's really about a partnership with you. And one of the goals of this regional community workshop is to educate you, but also to empower you to be a part of that decision-making so that you come in knowledgeable and understanding. You may not understand all the details of the chemos that we're going to be talking about, but it's important that we have that understanding of the disease, and that will empower you to have a more fulsome discussion. One of the things that we feel strongly about at the IMF is that patients should have the opportunity to get an expert. Sometimes I don't use the word second opinion because it gives you the sense that maybe the first one was wrong. And they could be absolutely right in the first opinion. But in a disease that is as complicated as myeloma, that's one of the things that the info line is there to help you with, is really to try and find ways to give you that expert opinion to guide the therapy that you have in multiple myeloma. So I'm going to conclude by saying we have a lot of drugs in myeloma. I can't speak for Kevin because he's so youthful looking and I can't tell when he really started in myeloma, but I can tell you I started in myeloma over 20 years ago. And this slide and the next slide could have been easily put into one little box of 3 or 4 drugs. That's all that we had. But now we have all these different classes of drugs, and the classes just keep growing. And it's really exciting. And I'll come to the end and talk a little bit about that later when we talk about relapsed myeloma, of all the new things that we have in myeloma. So I'm going to just skip ahead here because I'll talk a bit about this later in my other discussion. But I will end with what I think is kind of a futuristic but exciting slide. If you think about myeloma, the myeloma cell, and how we target it, in the old days, we used to give the so-called, if I can use the word, bald and barf chemotherapy. You know, we used to just give big whopping doses of chemo, blasts everything, and we hope that the good cells grow back. Now we've developed strategies to really precisely focus our treatment on the myeloma cell. And one of the ways we do that is we find these things that stick out of the myeloma cell. And I know these letters are confusing and half of them look like license plates, but these are the things that we can target in multiple myeloma. And we've developed all these treatments that can specifically target something on the outside of the myeloma cell that's not present in the cell next to it. That's the targeted therapy. That's the silver bullet that we've been longing for and that we have now in multiple myeloma. And I conclude with always my favorite slide, which I always have to update every couple of months because there are just so many more new drugs coming all the time that it really is amazing. Whether it's a frontline therapy or when the disease comes back, we keep adding to our list of drugs that we have in multiple myeloma. My final few slides are regarding disparities, as I've mentioned. You know that we have a call to action here because although we've made this huge improvement in myeloma, we've also sadly seen that that improvement has not fully been seen within the African American community. And these are 7 key facts that I share. I've already shared some of them with you, but very briefly, it takes longer to make the diagnosis in multiple myeloma. I love that I move my hand so much. The Zoom thinks I'm raising my hand. For everyone, on average, it takes time to make a diagnosis. The average person sees their family doctor 3 times. The signs and symptoms consistent with myeloma. This is longer if you're African American or Latino American. As I've mentioned, African-American patients are younger. They're twice as likely to get myeloma. And sadly, they're less likely to get the treatments that we know have historically really improved survival in myeloma. The combination therapies, the transplants, the clinical trials, and the CAR T-cell therapy that I'll be talking to in a little while. Interestingly, African-Americans are actually less likely to have what we call high-risk myeloma. I talked a bit about those cytogenetics. We have different cytogenetic profiles within the African-American community that typically mean that they have less high risk. So you'd think that they would do better, but as I said, their survival is half that of white Americans. However, we do have hope, especially as we've seen in the VA system, that when given equal access to that diagnostic and treatment approach, African Americans can live just as long, if not longer. And this is why we've created the Empower program, where we seek to engage the community and raise awareness around myeloma. In a couple of days from now, Kevin and I will be together in Richmond, raising awareness at Ebenezer Baptist Church there. If you happen to be in Richmond on October the 10th, please join us. And we want to engage the community to help them understand myeloma and how it affects them. We want to educate the primary care providers so that the diagnosis can be made more quickly. And we want to do everything we can to enhance the care of myeloma patients. And so we have done this both locally and nationally in all sorts of different venues and capacities. And we want to continue to reach every patient possible with multiple myeloma to provide them the kinds of resources that we know will help them through their myeloma journey. And as Robin showed to us at the start, we have lots of different things to help you in that journey. And we trust this will be helpful for you. So at this point, we've got 2 sets here. We may have to, I'll turn it back to you, Robin, and I'll skip ahead to the next set of slides. I think that's what happens. We ended up with 2 sets of slides here.
All right. Well, Dr. Joe, thank you, because I feel like when you're new to myeloma, it's like learning a new language and understanding the language and starting to feel like you can ask better questions. This is the start of your education in myeloma. And even as Dr. Joe said in the beginning, as you live longer and well with myeloma, things continue to change. And thank you so much for bringing up, we were almost there at Kevin's slides.
Oh, it's right here.
There we go. There we go. Okay. And Dr. Joe, would you like to introduce our friend Kevin?
Absolutely. So, Kevin, it's such a privilege to have you with us here. As you can see, Kevin has, as I sometimes jokingly say, more degrees than a thermometer. He's done a lot of training in his career, as you can see. But Kevin Briggle is a nurse practitioner that works at the Massey Comprehensive Cancer Center at VCU in Richmond, Virginia. He's also a member of our Nurse Leadership Board, and I've had the privilege of sharing the stage with him many times. I'm very grateful for his commitment to his own myeloma patients, but to the greater myeloma community. And he's going to talk to us a little bit about taking the reins of your multiple myeloma care. So Kevin, we'll turn it to you.
Okay. Thanks for that nice introduction. And you are correct. I got my flu vaccine today. So we're making antibodies right now as we speak. So this slide deck, I should say, is you know, I'm a member of the Nurse Leadership Board. This slide deck is actually put together by a group from the Nurse Leadership Board. There's about 20 of us. And it's an international board. We actually have members from Germany and Australia as well. And we're really charged with putting together programs for both patient and nurse education. And so that's kind of where this comes from. And each year we kind of put together a theme, and the particular theme of this one is really the people liked horses. So today's topic's stable of treatment. We'll talk about myeloma treatment and options. That's really the main part of it, finding your gait and going the distance. There are a lot of slides on this deck, and I'm going to skip over some of them because I think Dr. Mikhael is going to be covering some of the stuff that we'll be talking about later. But if anybody has any questions of any of the slides, which I might skip over quickly, be sure to put those in the chat box then as well. And so when we talk about today's topics then, so again, the stable of treatment, treatment options, side effects, and symptom management is going to be the bulk of this here as well. So treatment goals, when we think of treating multiple myeloma, there's really two ways we look at it. First is actually treat the disease, and those are with the myeloma therapies. And so the idea of the myeloma therapy is get that rapid and effective disease control. And in doing so, we can often basically take care of the symptoms that a person's experiencing at the point in time. And again, we want disease control, hopefully improve overall survival. We want to minimize side effects, whichever regimen we're using, and we have lots of regimens, and promote the quality of life. The other thing we think about are the supportive therapies. And the supportive therapies really aren't designed to kill the myeloma cells, but rather to prevent those disease and treatment-related side effects. We try to protect the bones and things like that. It's really symptom management, and that's really a big component of what we do in myeloma and myeloma treatment. And again, the goal here is to really promote the quality of life. And so when we think about treating now, we actually managed to get in our slide deck all the drugs on one slide here. So, but this is something that Dr. Joe had mentioned as well. So across the top, you have all these drug classes, and below them, you have the various drugs that are within those classes. On the left, we have kind of where they're positioned in the frontline maintenance of relapse. And as mentioned, that we have a lot of options here. So the MIBs are all the proteasome inhibitors. The MABs are the various monoclonal antibodies. The MIDES then are the IMiDs that a lot of people here probably experienced, the Revlimids and Pomalyst. Steroids, unfortunately, they are there. The alkylators, and if you've had a stem cell transplant, you've had the most common alkylator, which would be melphalan. If you go clear to the right on the others, we got a couple unique ones, selinexor, which is a selective inhibitor of nuclear export. We have a couple that yet aren't approved, Venclexta and Blenrep, which work on their own ways. And probably the new and just wonderful drugs that have come up in the past couple of years that are the immunotherapies, and those would be the bispecific antibodies and the cellular therapies. So we have 3 bispecific antibodies listed there, and 2 CAR T therapies then as well, the ide-cel and the cilta-cel. And so if we think about those, and we think about all those various drugs, and I talked about the melphalan, which some people may have experienced. And so upfront transplant really has been the standard of care for over the years. We're doing some studies now to see if that maybe can be supplanted by CAR T. But when we think of the various phases of stem cell transplant, we think of phase 1 is eligibility. That's really getting a referral to the transplant center, and then they basically evaluate you to see if you are eligible. And in terms of being eligible, there are a variety of studies that are done, including cardiac studies, pulmonary function tests, and things like that. Of course, insurance authorization. Patients need to have a caregiver then as well. And so that whole evaluation takes place then. And then once you've actually completed your induction therapy, then there's the actual transplant. So prior to the transplant, the stem cells are collected. You get the high-dose chemotherapy, which would be the melphalan. Basically wipes out your entire bone marrow, the good cells and the bad cells, hopefully all the myeloma cells, and then we reinfuse those stem cells. And the next couple of weeks is really supportive care while you engraft, and that usually takes a couple of weeks. And then from that point then, we go into what we call the post-transplant stage, and that really goes up to about day 100. And that's really just recovery from the transplant, the reinfusion, so performance status increasing, your appetite coming back, and then at day 100, we typically do a reassessment. It's going to be a bone marrow biopsy for the most part, and then we think about starting maintenance therapy, which we have a couple of options, and I know Dr. Joe is going to go into some of those options of maintenance therapy as well, as we've learned a few new things. So what in place of the stem cell transplant then is we think about CAR T as another treatment approach. And it's an absolutely fabulous approach as well. It recently moved up to second-line therapy. It had been fourth-line therapy. And the pathway here is a little different. And here again, patient selection, and that's referral to the CAR T center. And then if we're eligible, then we do this apheresis. It's like collecting stem cells, only we collect T cells instead. And then there's this kind of the manufacturing stage, and this can actually be the choke point, where it takes 4 to 6 weeks for the company to actually manufacture the cells, and sometimes they have some flaws in their manufacturing, so that can really be the weak point. And sometimes we actually need to bridge patients with additional therapy until they can get their stem cell, until they get these manufactured cells back. Then we go to the treatment phase, where we give a little bit of lymphodepletion, a little bit of chemotherapy, infuse those T cells back in there, those re-engineered T cells, and then we wait for those T cells to take over and basically repopulate into the bone marrow then as well. A number of side effects at that point when we do the infusion. And you can see a couple things here, the CRS and the ICANS, and so that's cytokine release syndrome and some neurotoxicity. And I'm not going to go deeply into those, but I think Dr. Joe will probably go into those then as well. But again, CAR T is another approach. It is a living drug. It's kind of a one and done. And so that's actually the advantage of this therapy then as well. We think of the other type of immunotherapy then are the bispecific antibodies. The bispecific antibodies are a little bit different from CAR T. CAR T takes a T cell, re-engineers it to recognize the myeloma cell, whereas the bispecific antibodies actually utilize all of your T cells to try and recognize the myeloma cells. And right now, it's currently approved after 4 lines of therapy. The benefit over CAR T is that there's no wait time. So with CAR T, I mentioned it's going to be 4 to 6 weeks while we manufacture the T cells. Here, if you need the bispecific antibody, we can start it within the next couple of days, depending upon insurance approval. It's going to have the same problem with CRS and neurotoxicity, these risks of infection. You can see over here on the left how they work. There's a target on the myeloma cell and all those targets that Dr. Joe talked about. And so the bispecific antibody will bind to that target, and then it will engage the T cell, the CD3 on the T cell. We get this release of cytokines, which kills the myeloma cells, also can cause the problems with the CRS. And that's how these work. So again, utilizing all the T cells that are available to target the myeloma cells. And so the couple of targets which we have available right now are the BCMA target and also the GPRC5D target. And there are others coming down the line then as well. And so the 2 things I'm not really going to go into are the CRS, or the cytokine release syndrome, which could be, again, a problem. And but again, those cytokines are what kill the cells then as well, and the neurotoxicity. But we can get onto some other things, and these are some side effects to manage, and these are things that we see every day. Of course, the steroids being probably a public enemy or patient enemy number 1. Why do we use steroids? It's because they work. They worked for a very long time. We've used them since the 1960s. They kill the myeloma cells very well. Unfortunately, it requires very high doses, and that can be a significant problem. The steroid side effects are shown over here on the right. Probably the big ones: the irritability, mood swings, depression, difficulty sleeping, fatigue. And for patients who have diabetes down the right, you can see the increased blood sugar levels and things like that, which can really be problems. How do we manage those steroid side effects? Well, there's a couple of things we think about. Consistent schedule. Take them in the morning or take them in the evening. Pick a day. The next day is usually going to be the challenging one after the steroids. And so pick a day that you're a little able better to function. If you work 5 days a week, you might choose a day that you're not working then as well. Take them with food. You can get some stomach discomfort with these because they do cause acid then as well. And we can often give medications then as well. Sometimes some anti-anxiety medications to help with the problems with the difficulty sleeping. And for patients who have the diabetes, sometimes those patients are going to have to go on insulin during the times that they're taking the steroid then as well. And so we think the steroids as well, they're great, but again, they can impact the immune system, as can all of our myeloma treatments. And the IMWG consensus guidelines here points out that infection remains the leading cause of death in patients with multiple myeloma. And so that's incredibly important. Up on the right, you can see what we tell every patient: report fever, shaking, chills, dizziness, shortness of breath, low blood pressure. Those things are essentially medical emergencies to us, and those things aren't something you should say, well, I'll call in the morning. Those are very important guidelines which we give patients. Infection tips shown down here at the bottom: the good personal hygiene, environmental controls, avoid crowds, wear the masks, clean off things that we commonly use, such as remote controls, iPads, refrigerator handles, and again, get your immunizations that are available. And sometimes we're going to go then into supportive meds then as well. And some of the supportive meds which you might be familiar with for herpes reactivation, CMV reactivation, we typically use acyclovir prophylaxis. Pretty much every patient is on these. We worry about PJP, so we use Bactrim then as well. Fungal infections, sometimes fluconazole for patients, especially those patients who have gotten CAR T or on bispecific antibodies. IVIG is extremely important, and so it's important to be checking your endogenous IgG level, and usually below 400 is where we start to see problems with infections then as well. We can get growth factors then if we need to. So GCSF is a very common one when patients get neutrophil count less than 500. And of course, for COVID infections, we do have antivirals, which can help us get over them then as well. I'm going to skip over the nail and side effects as they're very specific, and the oral ones very specific to one of the bispecific antibodies. So I'm going to skip those. GI symptoms, again, this is a big one. Fortunately, with most of our myeloma treatments, we don't get a lot of nausea or constipation. I mean, we don't get a lot of nausea or vomiting, but diarrhea and constipation can be pretty common. And it's not really related always just to the medications that we're giving you, but you have to take care and think about what are some of those over-the-counter medications and supplements that you might be taking. So laxatives, there are some cayenne, saw palmetto, and things like that, which can cause diarrhea. With constipation, the opioid pain relievers, some supplements such as calcium, vitamin D, certainly iron can cause those problems as well. So when we think about managing those things for diarrhea, we can manage them with over-the-counter medications. Sometimes we need to use prescription medications. For constipation, we manage that with over-the-counter medications then as well. So the GI side effects, we've been managing those for many years with other diseases, and so I think we're pretty good at that part. So it's just a matter of getting yours under control. And again, whatever symptoms you have, you just need to tell us, and I think we can work on them. Pain is a big one. Very often patients present with pain as well, especially bone pain. Later on, patients will often present with neuropathy secondary to the medications that we're giving them. Management, number one, prevent the pain when possible. So the bone strengtheners, that supportive care, the Zometa, the denosumab, those things to help prevent fracture risk is very important. The antivirals are important to prevent shingles and the pain associated with that then as well. Other interventions that we're going to give really depend upon the source of the pain. So we may include surgical interventions. Radiation therapy is very good for taking care of bone pain. There are complementary therapies as well. Acupuncture works very well for some patients. And there's a scrambler therapy that also can work quite well for neuropathy. I'm going to skip over the sleep one. Everybody needs more sleep, so I'm not going to go over that one. Big one here, and so this is probably one of the biggest when we think of public enemy. Number one for providers is the peripheral neuropathy, because if patients develop peripheral neuropathy, sometimes that can keep us from actually giving treatments that we would otherwise be able to give patients. And so it really is just damage to the nerves, typically in the extremities, and it would kind of a glove and stocking type of fashion. The symptoms you can see over here: numbness, tingling, prickling, sensitivity. Knowing those symptoms and reporting those symptoms are really, really important, because the key to controlling peripheral neuropathy is actually preventing it. Once peripheral neuropathy develops, especially as it gets worse, it often will not go away. So preventing it, being aware of those symptoms, and letting your providers know that you have the neuropathy is probably the most important thing. And so prevention management, again, the bortezomib, main side effect of that is going to be neuropathy. When we think of the fingertips and then the feet and things like that, massaging the areas with cocoa butter, there are some supplements you can use as well that can be helpful. Sometimes we have to adjust the treatment plan. Sometimes we have to use oral and topical pain medications in as well. Physical therapy could be help. But again, the key thing here is prevention, not management. We would much rather prevent it than management. And these drugs, if we have to do dose reductions, those drugs work very, very well at lower doses as they do at higher doses. And the lower doses can often prevent you from having neuropathy that is going to be basically something that will not be able to go away. I'm going to skip the kidney function for the part here. And so why the long face? And here's your stable of treatment. And so fatigue, 99% of patients report fatigue as a symptom. And so a lot of sources there: anemia, pain, reduced activity, the treatment toxicity, just coming to the clinic for, every week. That's a big one. And these are often associated, we kind of call this as a triad. The fatigue, anxiety, depression often appear together. And so patients often don't tell us about these things. We do hear about fatigue, but often not anxiety or depression. And sometimes if we can take care of one of these, just one of the triad, we can take care of the other ones as well, because they very often appear in person. And as Robin mentioned right at the start of this, your voice counts. And so being able to manage any of these, this triad of these problems, it can be very, very helpful. in the long run. Here's some additional supportive care. Again, I'm going to skip over that one in the interest of time. Huge one, financial burden. And financial burden, you can see over on the left, all the problems, the medical costs, premiums, co-payments. And it's not just for the patient, sometimes the caregiver as well, because the caregiver has to take time off to bring the patient here then as well. So there's a lot of costs that can be associated with having myeloma. There's a lot of funding that can be available here. There's a whole list of them here shown on the right. If you have access to a social worker wherever you are, they're really, really helpful in terms of finding a lot of these different programs, and a lot of the companies who you might be getting your medications from. You can go onto their websites, and very often they have programs that you can apply for funding then as well. Finding your gait, be an empowered patient, engage in your care. And once again, as Robin said at the start, your voice really, really does matter. Be empowered, ask questions. You don't know what questions to ask? IMF has great tip cards with questions and things that you might want to consider, talking about your goals and your preferences. Communicate with your team. And I do see the myeloma specialist up there. That's Dr. Joe. He's sitting there right there. But you have a huge team, or hopefully you have a huge team from your medical oncologist, the radiation oncologist, your nurses, your advanced practice providers. You might have pain management. You may have social workers, a whole variety of them as well. And again, the big communicate with that team is your support network. So think about your primary caregiver and anyone else that you can involve in your care then as well to help your caregiver. I'm going to skip this one as well. Knowledge is power, and this was brought up before. There's lots of these various types of things that publications that are put out by the IMF, and you can either get them online or have them sent to you then as well. But the website is flush with lots and lots of good options then as well. And going the distance, we're going to finish up here, and I think I have just a little time left. Helpful and meaningful living. And so the care partners, I think this is absolutely crucial. We're finding more and more that care partners is absolutely essential for going the distance in as well. They help with lots of different things, not just taking you to appointments, but often managing medications, assistance, emotional support. They're the person there who will listen with you and when you're at your appointments, and they often will hear different things than you hear as well. Your care partners can be anybody who's associated with you, your spouse, a relative, anyone of family, friends, neighbors. And probably what we know most is you got to care for the care partner as well. For people who've been care partners, they can often be more challenging and more difficult than actually being the patient. So there's really never time off when you're a care partner then as well. So when we think about helping your care partner, it's really building a strong network, and you can build a strong network in a lot of different ways. And so, again, deepen those relationships. What are the relationships you have from other clubs, organizations, and things like that, people you volunteered with? But you cannot have too big of a caregiving network. And so there's actually tip cards, building your support network, put out by the IMF as well, which tells you how to do that, and good ideas from that pathway. And then lastly here, the one thing here, maintain good health. And Dr. Joe was saying, 20 years ago, the people didn't live very long. Median survival was maybe 3 years in this. And so back then we didn't really care that much about getting a colonoscopy or mammogram, because 3 years we were really just trying to really manage the myeloma. And now when patients are living 10 years and longer, really important to get these recommended health screenings, the blood pressure, cholesterol, colonoscopies, mammograms, and things like that. Again, maintaining a healthy lifestyle, because while 10 years might be the what we think about as a kind of a median, we really like to think that people can go a lot longer than that. At some point, we may be able to cure. And so maintaining a good, healthy lifestyle for both you and your caregiver is going to be critically important then as we go on. And I know there's no Q&A here, so I'm going to turn this back over to Dr. Mikhael.
Great. Well, thank you so much, Kevin. I know it might feel like everyone's sort of drinking from the fire hose here because there's so much great information, but one of the things, as Robin had indicated, and she'll remind us too at the end, is that not only is this recording obviously going to be replayed, so you don't feel like you have to catch it all, the slides are made available to you as well. So we want to give you that a little bit of a rapid fire overview of many things, but we want you to be able to have the capacity to look these up later and to find them so that you can go through them in more detail, especially if there's a particular area that's of value to you. As I noted before, unfortunately, Dr. Hartley-Brown is not able to join us today. So she was meant to give this frontline therapy talk, but I will walk us through this as we think about it. And what I want to achieve in this next section, and then we'll have a little an opportunity to answer some questions, because I can already see a whole set of amazing questions coming in. I almost wondered, I said, did someone preset these questions, or are these all coming in live? They're all coming in live. So this is great. Thank you for your interest, by the way, and thank you for your great questions. We'll get to as many of them as we can. You might want to have some Wheaties, Kevin, between now and the Q&A, because we're going to have a lot of questions to answer. But what do I want to do in this next session is to review the importance of the initial treatment of myeloma, and in particular, getting into what we now think of as a deep response. I'll explain the difference between depth and duration, but the concept of getting the disease down when it's first diagnosed, because typically when it's diagnosed, there's a lot going on. Sadly, a lot of damage to the body, as Kevin just shared with us, and we want to bring that down. And then I'll talk about really what's new, what's kind of the standard of care, but also what's new, whether someone is getting a transplant, so-called transplant eligible, or someone is not getting a transplant or transplant ineligible. We'll walk through the two of those. So just to sort of think about it conceptually, we think of sometimes this iceberg model of myeloma. What does that mean? It just means that obviously there's a lot of ice at the top, but as you go down, you're getting deeper and deeper and deeper, and there's lesser and lesser and lesser ice, but it's harder and harder to get to the bottom of it. And myeloma is a little bit like that, where we have this kind of upside down triangle here, where as we treat, we get rid of that big bulk of the disease. But as we're starting to learn, now that we have all these amazing therapies that Kevin shared with us, we know that we can get to almost to the bottom, if not the very bottom of myeloma, because that's what ultimately is going to take us to a cure. So even if we don't really think of myeloma yet as being fully curable, we know that we can control it by getting into a deep response. I was having this discussion with a patient today, and she said to me, Dr. Joe, am I in remission? What does that really mean? Because sometimes people hear the word remission, they sort of think that it's cured. That we use the word remission to say that we've brought the disease down by a certain percentage. If we've at least cut the measure of the disease, whether, as I said earlier, it's an M spike or the light chain, if we cut it by 50%, we call that a partial remission or a partial response. That's really considered remission, meaning we consider that a responder when it's at least cut in half. I know you say to me, well, don't we want to cut it more than half? Well, of course we do. But we know that from a kind of prognostic standpoint, that even cutting it in half makes a big difference. But then if we cut it by 90%, it's called very good partial response. If we cut it by 100%, it's called a complete response. And then more recently, we've even added new terminology to what we do as we think a little bit about trying to get that arrow all the way down to the bottom, is that we've even now developed something called MRD, or minimal residual disease. What that means is you're getting down to where you can barely measure the disease anymore. So typically what happens here is that M spike, or those light chains that we're following, gets completely normalized. So now we go into the bone marrow to start looking, are there any of those evil plasma cells left? And when we talk about someone being MRD negative, it means we can't find one plasma cell amidst 10 million or sometimes even 100 million cells. So it's incredibly sensitive technique to detect any disease left. And we believe this is very important because it's the step towards a cure, that if I get that really deep response, then that's going to correlate into what we call a durable response, right? Because it's one thing for someone's numbers to go down, but we want them to stay down. And I know this is a bit of a complicated slide, but I'm just pointing out the green line. The green line shows to us that when people get into that lowest response, that best response, all the way at the bottom, the MRD negativity, it translates to them staying in remission longer and even living longer. than any other kind of response. Now, there's always exceptions to the rule. There's some patients that don't get that deep response, but still live a long and great life. So we can't put everybody on the same curve, but it's teaching us that we want to get that deep, deep response. And so the reason why I start with this, one is to explain what MRD is to you, but also as we start looking at some of the studies I'm going to share with you, we look at how deep the response is with the different strategies that we have. So when people are typically diagnosed, we put them, as I mentioned, into pretty much two buckets. Are they eligible for transplant or ineligible for transplant? That may change in the future and our terminology may change, but that's pretty much the standard of care now. And it's not based on age alone, it's based on a number of factors, although historically, we've thought of a cutoff around 75, meaning people who are under 75 could be eligible for transplant, and most people over 75 might not be, but of course, there are exceptions to that. I remember a patient of mine once who was in his late 70s, I'm sure could outcycle any of us. I mean, he was in incredibly shape. And then sometimes there are younger patients that may have other heart or lung or kidney conditions that may make it more difficult to do so. But in general, that distinction is made, and we'll come back to that in a moment. And with that distinction, I just want us to think a little bit about the principles of therapy, because I don't want this to be a big data dump where I just give you all sorts of studies. I will get to some of them, but I want you to understand the principles first. And the principles are, most people are going to be given multiple drugs together. We don't have one magic pill for myeloma. I think of it like how we overcame HIV was not because we came up with one great drug, it was the right combination. Point number two is we don't save the best for last, meaning we try to use the most effective therapies we have upfront. What we do frontline makes a big difference because we want that deep and durable response. And typically in the frontline setting, we're pulling drugs from three major classes: the proteasome inhibitors that Kevin showed us, the immunomodulatory drugs, and the monoclonal antibodies. So typically from the proteasome inhibitors, it's Velcade. Typically from the immunomodulatory drugs, it's Revlimid. And typically from the monoclonal antibodies, it's either daratumumab or isatuximab, also known as Darzalex or Sarclisa, after we've made that decision about whether or not someone is going to go to transplant. Well, this just in, over the last few months, we used to choose, if you will, 2 out of those 3 and add some dexamethasone for our myeloma cocktail, as it were. Well, now we've actually learned that if we take one of each of those classes of drugs and add steroids, so that's now what we call a quadruplet or a 4-drug combination, is now the standard of care in multiple myeloma. Darzalex, Velcade, Revlimid, and dexamethasone for patients who are transplant eligible just earlier this year was approved by the FDA for use. And then literally just a couple of weeks ago, for transplant ineligible patients, we saw the quadruplet combination of Sarclisa or isatuximab added to Velcade, Revlimid, and dexamethasone being the new standard of care based on the IMROZ and the BENEFIT study. And then literally just a week and a half ago, not yet FDA approved, but I mean, literally hot off the press, at our International Myeloma Society meeting in Brazil, we saw the results of the Cepheus trial. And I'll just talk to you a little bit about some of these, just so that you can get the concept. I'm not going to go on diving in detail. But the Perseus study that has really changed what we're doing in frontline therapy for patients that are transplant eligible. For many years, we gave the 3-drug combination VRD, Velcade, Revlimid, Dex. And this study, in a large, what we call phase 3 study that sort of compares what's the standard of care to seeing if we can make something better than the standard of care, they added, Darzalex to the VRD before the transplant, for a little while after the transplant, and then in maintenance. And I'll come back to the maintenance discussion after our break later. But here we saw the question was really, is 4 drugs better than 3? And you don't have to understand how these curves work to say there's a difference in the curves. What this means is at 4 years, at 48 months, the people that got the quadruplet therapy, 84% of them were still in remission, whereas with the VRD, about 2/3 of them were still in remission. So that difference tells us what adding that fourth drug could do. And that was, of course, driven by a difference in the response rate. About 88% of people had a response with the 4 drugs and about 70% with the 3 drugs. Oh, sorry, not response. These are people that got into what we call complete remission, those that got that almost to the base of the iceberg at complete remission. So really quite impressive for Perseus. And that really changed what we do. But then just a few months ago at ASCO, which is our cancer meeting in June, and then just last week in Brazil, we saw the updated results of what was called the IMROZ study, which took a very similar approach. And I know there's a lot of complicated colors and so on here, but I'll walk you through it, of adding isatuximab or Sarclisa, the other drug that is similar to daratumumab called a CD38 monoclonal antibody, and added it to VRD. But in this situation, these are patients who were not going to transplant. So they would get this continuous treatment, not stopping for transplant, and wanted to see if the 4 drugs were better than the 3 drugs. And importantly, these were patients that, you know, are typically of the age and performance status that we're not going to transplant, meaning, as you can see, only 3% of patients were under the age of 65. The majority were over 70 years old with an average age of 72 in this study. And what did it show? Again, just looking at the curves, this time at 5 years, because remember, these tend to be older, more frail patients, so it's a little bit different to compare it to the study we just saw, but you compare it to the 2 different lines. The purple line, we saw that about 63% of patients at 5 years were still in remission, only having had this one type of treatment, whereas with the VRD, that was about 45%. So that improvement of almost 20% favored using the quadruplet. Now, I got to say, in this study, patients over the age of 80 were excluded from the study and weren't included. There was a second very similar study called the benefit study that I won't go into detail, but I show this for only one reason. The big difference between this study and the one we just showed was that the Velcade here was given once a week instead of twice a week. And in this study, patients seem to tolerate it a little better. And I'll make a comment about that in just a minute about how we give Velcade. So I would give my Dr. Joe commentary here by saying quadruplets really are better than triplets in those patients going to transplant. And I think that's now the new standard. And it's catching across the country. It's now FDA approved. We really should be using this in the vast majority of people that are going to transplant. For those who are not going to transplant, we have similar evidence. No surprise, whether you go to transplant or not, myeloma is myeloma. The biology is pretty similar to no matter what the age of the patient or performance status of the patient. Maybe we have a little less evidence in those patients over 80, but the other feature that I think is really important, and I know Kevin mentioned this in his talk, and I really appreciate that part of it. One of the reasons why it's just so important for us to work as a team with doctors and nurses and physician assistants and pharmacists and others is that we can't always take this one size fits all to myeloma. And in particular, in older, more frail patients, as we get older, it's just harder to tolerate the same amount of treatment, that we have to be willing to make dose adjustments. And so typically, even though the clinical trials have to give, if you will, the full dose, we often give lower doses of Revlimid. We often give Velcade once weekly, and we also give less dexamethasone. And people know that I get on my soapbox when I talk about dexamethasone. I got to show you in my next slide in a moment my sentiment about dexamethasone. But it is really exciting that just in the last few months, we now have 2 major FDA approvals for DVRD and transplant eligible, and Sarclisa or isatuximab VRD for transplant ineligible patients. Now, the comment I was going to make about Down with Dex, and I'm kind of preemptively showing you a picture that has not even been published yet, but will be soon, is I had the privilege of writing an editorial in one of our journals called Blood with our nurse practitioner, Susie Harding, discussing this notion that back in the day when Kevin and I started, we were giving really high doses of dexamethasone. In 28 days, people were getting 12 days of 40 milligrams of dex. We made this tidal shift to low-dose dexamethasone about 15 years ago now, where we're giving it only once weekly at 40 milligrams. But I'm going to suggest that we're going lower, and we're starting to realize that staying on dexamethasone is not necessary. And I'll give you this little teaser so that you know that we're working on finding ways to give even less. Well, I've shared with you the new data for these quadruplets. But people always still ask the question, and I got asked today in clinic, Dr. Joe, do I still really need a transplant? Well, we don't have the perfect answer to that. It depends who you ask, right? You ask a transplanter, they say yes. You ask a non-transplanter, they say no. But we have had a few studies, including what's called the determination study, that tried to at least partly answer this question, where this was before we were giving quadruplets, we were still giving the triplets. But the question was, what if I just give the triplets and skip the transplant, or I give the transplant? Is there a difference between those two arms? And that's what they looked for. And it actually showed that if you got the transplant, you stayed in remission longer. And the difference between that so-called progression-free survival, which is really a reflection of someone staying in remission, was quite significant, was about 20 months different if you had the transplant versus not having the transplant. But interestingly, the so-called overall survival didn't really make a difference. And this was partly lots of different reasons that can explain this. I won't go into detail. But this is why there's still some debate about whether or not you absolutely need a transplant. Maybe you can just delay it for later. But as I always say, you're the champ until someone knocks you out. And right now, transplant, if you will, still remains the champ. It's not like everybody has to go to transplant. Often I find myself in clinic, and Kevin, I suspect you find the same thing once in a while. You're giving patients permission to not have a transplant. It's not always absolutely necessary, but it still has value. We saw that when people go through transplant, their quality of life does dip for a significant period of time, but does seem to come back. And so when we discuss this study, I try to be balanced. I say, look, transplant is still relevant. It's still very active, and it still works to prolong progression-free survival or the time in remission of younger patients, but it may not be mandatory for everybody. I think we have to individualize our choices. Again, one of the reasons why we even host a workshop like this, so that you can be engaged and informed in this discussion, so you're not just saying, oh, this is what I have to do versus what I don't have to do. You have choice in the matter. We know the transplant does come with some toxicity, side effects, both in the short term and the long term. And we also know that maintenance is important, but of course, I'll come to maintenance later. Another question I get asked often is, well, do I have to stay on treatment forever? I mean, can MRD guide us in stopping therapy? And there was this study, fascinating study called the MASTER trial, and now it's being reproduced in different ways, that said, you know what? Instead of just treating people forever, which is kind of what we do now, let's treat people very intensely, but let's check. And if they get to that MRD negativity and they get there twice, what they call MRD sure, so at least 3 months apart, they have 2 MRD negative measures, maybe we can stop the treatment. And I know this may be a bit complicated to see, but staying flat along that top curve is a good thing. And for a lot of patients, they were able to stop treatment and stay in remission. But what we learned was there was a difference in those patients that had what we think of as high risk or even ultra high risk myeloma. This goes back to the very first lecture we had today, where we said we divide people into so-called high risk and standard risk multiple myeloma. About 75% of patients are standard risk, about 25% are high risk. And we've learned that it's harder to stop treatment, or I should say, if we stop treatment in those very high risk patients, their disease comes back very quickly. So we still have some work to do on this whole MRD business and stopping treatment, but we're getting closer all the time. Well, how do we decide if someone's eligible for transplant? Well, these are guidelines from ASCO that I had the privilege of leading a few years ago, and right now we're updating them, and we hope to have them out in early 2025. But an important thing here is age alone should not be the determinant. This needs to be a conversation between the patient, their care partner, their care team, the transplanter, to decide that. And so we just think it's important to remember that there's lots of different ways of measuring frailty, of measuring someone's candidacy for transplant, but that has to be done individually. It's not just based on age alone. Because sometimes we can't really use a quadruplet. And the triplet that we tend to use the most now is actually DRD, or adding daratumumab, Darzalex to Revlimid and dexamethasone. This was based on the MAIA study, that although these numbers may not be as high as what we just saw with the IMRA study, but we saw that these patients at 5 years, over half of them were still in remission when they received that triplet combination, and 2/3 of them were still alive at 5 years, which was before this study was done. This was really a major step forward because we didn't see that kind of outcome before. So we really do. I didn't get into a lot of the detail with smoldering myeloma, but I indicated that we typically don't treat smoldering myeloma. We typically wait until someone has true active multiple myeloma, but we do have now good evidence when someone's disease is active to treat them with a quadruplet. I would suggest that DVRD is the standard of care in transplant eligible patients. Sometimes we might switch out the Velcade for a different proteasome inhibitor for various reasons if we're worried about someone having neuropathy or something. But that really is the appropriate thing to get a quadruplet before transplant. And now we have the opportunity to give a different quadruplet in transplant ineligible patients with ISA VRD. Sometimes we may use DRD or Sarclisa DRD or Sarclisa RD. It may be considered in some patients. And although transplant remains a standard of care, I think we really have to be careful, not that it's about age, but we want to really be careful in those patients that may be at risk of having more complications in that roughly 65 to 75 age group. We've learned that giving these drugs more continuously has better outcomes, but we're hoping that we're going to find ways to eventually stop therapy in the vast majority of patients. And of course, I always say it's a balance between how effective a regimen is and how toxic or side effect producing it is. And so it's really important that we talk to our patients, that our patients talk to us and share what's going on, how experience. Today I was having a conversation with a patient who said, doc, I'm doing really well. It was the first time I met him. He was being managed by someone in the community. But he says, boy, every time I take that dexamethasone, I can't sleep. My wife says I'm grumpy. I get jittery. He has some other challenges with it. And so we want to look at that. As I've said before, we often can dose reduce the dexamethasone and taper it down. Lastly, it's an exciting area that I'll share with us in a moment, or a little later when we come to relapse therapy. But it is remarkable how this new treatment that Kevin shared with us, CAR T-cell therapy, has really had an impact in myeloma and in other cancers as well, and particularly blood cancers like lymphoma and leukemia. And we're now doing clinical trials and studies to see, can we be bringing this CAR T-cell therapy up front? The evidence isn't there yet, but we're generating that evidence to understand it. Because of course, as I've said many times today, what we do up front makes a difference in the long run. So trying to put this all together in my last two slides here, and this is with help from Dr. Vincent Rajkumar, who's the chair of our IMF board, who met with us and the support group leaders last month when we were walking through how we treat myeloma, that in newly diagnosed myeloma, you can see that whether someone is standard risk or high risk, typically we're going to a quadruplet combination, whether it's DARA VRD or ISA VRD. We might decide to go to a transplant and then to lenalidomide maintenance, or we may just save their stem cells, not immediately go to lenalidomide maintenance. But for those patients that have high-risk disease, and I'll come back to this in the maintenance study, the maintenance lecture, we may decide to give more than just lenalidomide maintenance. In those patients who are not eligible for transplant, we assess a little bit of their frailty. Are they, if you will, quad eligible or not? And if we feel that we can give them a quadruplet, we'll do that. If not, we may give them a triplet, whether it's VRD or DRD, as I outlined. So I'll show you this one more slide again to just see how we're stacking up the odds and stacking up all these options for our patients going forward. So maybe, Robin, I'll turn it to you if you have any other comments, and then we can, I tried to finish this one a little bit early so we weren't rushing so quickly, and it looks like we've got lots of great questions to go through.
Yeah, Dr. Joe, this to me, and especially ending on that last slide, that's a slide of hope. So we can all look at that and think about the variety of combinations and actually the importance, as you said earlier, Dr. Joe, of seeing a myeloma specialist. Not necessarily that, quote, second opinion, because no opinion is wrong, but again, just making sure that with all of this information, and myeloma being so unique to each person, which a lot of these questions that are coming in are showing the individualness of myeloma and why we need all of these different combinations, because what works for one may not work for another, and that's the tricky part, right?
Absolutely. Absolutely. Well, I guess we could dive into the Q&A here. There's lots of them. So I hope that Kevin's ready for a little bit of rapid fire. If I'm not mistaken, we have just short of 20 minutes and we have 23 questions at least so far. So we'll try and take them in stride. So question number one was, I was a participant in CAR T-cell therapy in the summer of 2023 and enjoyed 8 glorious, healthy months following that, but unfortunately relapsed again. I was then started on a bispecific treatment, but light chains are increasing after only 3 months. Is there any research about patients repeating CAR T therapy? So I'm very sorry to hear that the disease is waking up as quickly as it is. It's very humbling. You know, Kevin and I both share that we've seen such improvement in myeloma, but we still respect this terrible disease because there are times when it becomes very difficult to control. And I'm sorry that it has come back so soon. The quick answer to your question is, yes, we are doing research on this and we're collecting so-called real life data on this very thing. You know, the IMF has this massive immune therapy registry that we're building, where we gain this kind of information, what we're doing. I can tell you, even my own practice, I've had several patients in whom we've given a second CAR T to. Sometimes we may switch the bispecific to a different target, but that research is ongoing. And I know that you can speak to your provider about it and look at those options, because we are now more and more seeing these new therapies being given to patients that have already had a similar therapy to it. Number two, our region in southern Vermont seems to have high incidence of myeloma. Are there any researchers on your staff that want to conduct a study? I think the quick answer here is we're always interested in understanding myeloma better. And there are registries that are kept by the government, that are kept by the National Cancer Institute. And maybe this is something you can reach out to the info line about if there really is a sense of something in that area. The IMF has been involved in understanding myeloma after 9/11, sadly, in our first responders, where we saw a greater incidence with our work with our veterans, who sadly also have an increased risk of myeloma because of exposure to Agent Orange. So we want to help in any way we can. Number three, and then I'll come back to you, Kevin, for a couple of the subsequent ones. What does the current research say about stopping Revlimid 2 years post-transplant when a patient is MRD negative? Great question. I'll give a bit more data on it in the maintenance study, in the maintenance lecture. The short version is that we're still exploring this. I think it's a little too early to say because someone's MRD negative, we can stop. I think if someone has high-risk myeloma, then it's particularly clear that we shouldn't be stopping, at least for now, with the treatments that we have. If someone has standard risk and they've had MRD negativity at least twice and 6 months apart, it's a discussion. I think most of us are feeling that right now, we don't want to prematurely be stopping too many patients until we understand it better. In some of those studies that I showed you, they gave maintenance with a second drug for 2 years and then just continued lenalidomide, because right now the standard of care is lenalidomide until progression. The caveat, of course, is if someone is experiencing side effects, that changes the whole story, because we don't want to force people into treatments that they're not tolerating well. As I always say, I don't treat myeloma, I treat people. And so that's very important. Here's maybe, Kevin, if you don't mind taking this one. I was initially diagnosed as high-risk IgA kappa. I had transplant. I'm now MRD negative in remission. Am I still considered high risk, or is this diagnosis ever changing?
Yeah, you're still considered high risk. From that standpoint, you kind of don't change your flavor. And I think also when we think about MRD, the question is how many cells are still remaining, and are any of those cells still carry any of those mutations which made you high risk initially. So there's, again, once high risk, really always high risk, I guess. There's some thoughts about restaging patients, but again, at what level can we identify those high risk mutations?
And on that note, Kevin, let me ask you question 7 here, which is it possible for the FISH results to change over time? So can someone go, you basically told us that once someone's high risk, they pretty much stay there, but can someone go from standard risk and later become high risk?
Absolutely. In fact, when patients relapse, we again restage them and get new fish studies, because you can acquire more mutations as treatment goes on, as the course of disease goes on. I assume that's your standard as well, to restage with fish then as well?
Yes, absolutely. Absolutely. No, I completely agree with the way you've said it. Here's another question that perhaps you could take, Kevin. What is the cause of death with multiple myeloma? Is it kidney failure? Is it infection? That we want to dwell on that, but I think we have to be open and honest and talk about death when we talk about a disease that's incurable. What is the cause of death in many of our patients?
Well, yeah, absolutely. You don't want to dwell on this, but I could even say all of the above there for the most part. But with a lot of patients, it is I would, if you would think of a leukemia state where the myeloma takes over the bone marrow and just starts to basically prevent you from making your own red blood cells, your own platelets, your own white blood cells. And so patients will often become transfusion dependent. Patients will also often get infections because their immune system gets so corrupted. So infection is a common one. And again, sometimes it's just requiring transfusions, and it's just a time to say the transfusions aren't helping me feel any better. So I make a decision not to continue those.
Yeah, thank you for sharing that with us. I got to jump back to a question earlier that said, can you also talk about the exceptions, i.e. those who live past the stats you've just presented? And the way I answer this question is that, statistics are very, very helpful, but they're never 100% inclusive. So what does that mean? So when I say, oh, here's this great trial, and on average at 5 years, 60% of people are still in remission. What does that mean? It means that if we say the average time to relapse is 5 years, for example, that's just an average. Some people might relapse at 5 months, and some may relapse at 15 years. So there's always, if you will, outliers. Although we say the average survival of myeloma now is over a decade, tragically, I lost a patient this past year who passed away within 6 months of his diagnosis. On the other hand, we have people like the world famous Michael Toohey, who's been living with myeloma for decades, literally. And so we really see that huge spectrum. And that's why it's really important that, you can't say my doctor gave me 6 months. No, these are their average numbers. Every patient has to be looked at individually. Here's another one for you, Kevin. What makes one ineligible for a transplant? I know it's a tough question because there's lots of ways of answering that, but maybe you could give us some broad strokes.
Yeah, I think you covered that in your one particular slide then as well. I think there are certain cutoffs which some transplant centers use, that age of 80, things like that. So again, when we think about a person's performance status, what's their heart function, what's their pulmonary function, and things like that. Those tests are done ahead of time, and sometimes those can rule you out. And interestingly, we just think of the non-performance status things. It's like, do you have a caregiver? Do you have insurance? Are you able to do those things? And so you may be eligible. You may be one of those people who are 79 and eligible, but you don't have the support or the insurance to do that then as well. So that negates it. So a whole variety of things negate from being eligible for a transplant.
Robin, I'll get you to answer this question. Are the slides available to the audience?
Well, I am very happy to say that, yes, we are recording this webinar. So the slides, you can flip through the slides yourself just to capture what you might have missed in this rapid fire presentation. But you can also replay it so you can hear all of the good information that Dr. Mikhael and Kevin are providing to you. So yes, go to the myeloma website, myeloma.org, and click on videos and regional community workshops, and that's exactly where you'll find it.
Sweet, thank you. And I apologize if you go there and you end up seeing a lot of videos from me, but there's therapy for that. But we do try to provide a lot of information to you. So here's another question, which is good. How are the T cells in CAR T cell therapy modified before they are reintroduced? Wow, like this is a question I want to totally nerd out on and give a long explanation of. And I'm going to talk a bit more about CAR T cell therapy in a moment. But the short version is this. T cells are like soldier cells that live in your body. And Kevin described the process very briefly. And they have the capacity, if you will, to be trained. So what we do is we take T cells out of you. For those of you, for example, who've gone through a stem cell transplant, it's a similar process we call apheresis, where we hook you up to a machine, kind of looks like a dialysis machine. Your blood goes to the machine. We pick off the stem cells. Well, similarly here, we pick off the T cells this time and send the rest of your blood back into your system. So now that we have these T cells, we engineer them, as it's called. It's a pretty complicated process. It's actually, in some of the technology, was the same technology that we develop vaccines for. But with use of what's called a viral vector, we actually form a receptor on the outside of the T cell. That's where the word CAR comes in. CAR is an acronym for chimeric antigen receptor. So it's a receptor that goes after what we call an antigen. Remember, I shared earlier what antibodies were? Antibodies hook on to an antigen. It's just the way the wording is used. And so we can, if you will, train these T cells to recognize the antigen or that thing that sticks out of the myeloma cell. And I showed you the picture of all those license plate-like descriptions of things that stick out of the myeloma cell. And now, interestingly, we can also multiply them in the lab. We can also ensure that they multiply themselves when they get back into the patient. So now we've taken these Rambo-like T cells. We've said, look, soldier, this is who you're going after, showed them the picture of the bad myeloma cell, and then reinfuse them into the patient so that it can go and destroy the myeloma. And what's fundamental to T cells is they can travel throughout the whole body. So wherever there might be myeloma, they can go after it. All right, here's a good question. It says, explain prior lines of treatment. This is always a challenging question because sometimes the FDA gives us approval for drugs based on a line. A line of treatment is meant to describe when you are on a treatment until, unfortunately, your myeloma relapse. So it's not related to how many drugs you're on. It's more a function of until the disease wakes up again. So when I showed pictures of those patients who get a induction therapy or a 4-drug combination and a transplant and maintenance therapy, believe it or not, that's all one line. But when their disease wakes up and they get treated with something else, that's line number 2. When their disease wakes up again and they get treated, that's line number 3, and so on and so on. And so, which leads into the next question, which says, aren't there some bispecifics that can be used after fewer than 4 lines of treatment? Well, right now, the 3 bispecific antibodies that are approved, I showed their names earlier. I'll give a little bit more detail of them in the relapse talk. They're all approved only in patients who have had 4 or more prior lines of therapy. So it doesn't mean you've had 4 drugs. It means your disease has relapsed 4 times. So we hope with time we're going to be able to bring them earlier. That's typically how drug development works in myeloma. You prove that it can work in the very heavily relapsed setting, and then you bring it forward, just like we've done most recently with CAR T, because CAR T, as of April now, we can give it as soon as 1 prior line of therapy. Okay, we're doing pretty well here, Kevin and Robin. We're up to question number 14. Maybe, Kevin, I can ask you number 14. What's a better prognosis, continuous treatment or multiple remission and relapses? So should we do the start and stop, or should we give continuous treatment?
We should do continuous. Yeah. So we want to keep whatever's there in remission for the longest period of time. If we stop, we assume that whatever grows, it's probably the mean and angry guy, and he'll acquire more mutations and get worse and worse as time goes on. So continuous treatment has been the standard of care. So any comments on that?
Yeah, no, I mean, I think you're right. I think, obviously we hope with time. I mean, poor Robin has heard me say this 100 times, but I always say, look, my favorite drug for patients is nothing. I love giving patients nothing. Right? I mean, every insurance company covers it. Every patient takes it wholeheartedly. Side effect profile is perfect. I would love to stop treatment in all of our patients. And I think we will work towards finding ways of doing that. But the principle, the way I explain it as well, Kevin, to help people think it through is, what we've learned over time is if I give drug A until relapse and then drug B until the subsequent relapse, I'm going to get a certain amount of time out of those 2 drugs. But interestingly, if I add A and B together off the start, I get an even wider time in remission. that sort of synergy, that two people go together longer than two individuals would go separately. I think that's a beautiful picture of what happens in myeloma, that as these drugs work together, the tag team of the drugs works longer. And that's the principle behind continuous therapy and what we've been able to prove in clinical trials. Here's a good question. If you have light chain myeloma, will you have an M spike? And the short answer is no. If you have light chain only myeloma. Interestingly, a lot of people who have M spikes also have light chains. So we actually sometimes have two measures of the disease in the same patient. But if it's light chain only, there will not be an M spike. All right, we're good. We've already covered 15. Let's come to number 17. Is some organization keeping track of successful CAR Ts with people of African descent? For example, 2 or more years without treatment. Great question. And the answer is yes, we are tracking this. So there's multiple ways it's tracked. The FDA, of course, has a method of detecting various things, the companies that make these drugs. But in addition, we have a consortium of different CAR T centers, but in particular, this thing that I briefly mentioned, the IMF's Immune Therapy Registry, where we're getting all of the major centers across the country to anonymously provide information about their patients so that we can learn something that we could never learn individually in one site. This whole concept of big data is so important in multiple myeloma and in the world. And so if we can gain that information, we can. So for example, some of the early work we've looked at is CAR T different in its safety or efficacy in Hispanic American patients or Latino American patients or African American patients? Is it different in its efficacy? These are the kinds of questions that we're trying to capture. All right, Robin, I know we're down to one last minute. We may have to save some of these. Oh my goodness, the questions are still pouring in. But let me pull out one or two more to close us off, saying, are patients over 80 years old eligible for any advanced treatments, Kevin?
Yeah, I think it depends what you define as advanced treatments, but certainly there are clinical trials open as well, which are treating older patients with bispecifics. And I don't know about the CAR T ones. We don't have any available, I think, for that age, but certainly for the bispecific antibodies, absolutely.
Oh, in fact, even CAR T, I would argue, in the very first Abecma study with ide-cel, one of the 2 CAR Ts we have, patients up to the age of 84 were included in the trial. So obviously it depends on the scenario. And that's actually another question that someone asked here, where someone says, I understand that there can be a difference between a person's chronological age and biological age. Please explain this further. Well, chronological age just refers to what's on your birth certificate. But depending on how we live and honestly our own genetics, we all know you can see someone who's 60 years old and they may look more like they're 40 or they may more look like they're 80. And that's not to be critical. That's just to say the body reacts different ways to different things that have happened over time. And so as we get better measures of that biological age, it helps us choose the right therapies for the right patient at the right time. So I think we've done well in covering these first 20 questions, Robin. I'll turn it back to you. And I think looking at the other questions that are coming in, a lot of them have to do with what we're discussing later. So we'll try and get to them when we have yet another Q&A after our next set of lectures.
Perfect segue, and we're exactly on time. So good job. And everyone here, we're going to take a nice little break. We know how important it is for you to get up and stretch and move around a little bit. So take a break, and we'll see you back here at 7:15 p.m. Eastern.
Thanks, Robin.
Okay, welcome back, everyone. We hope you had a nice little stretch, a little break, maybe got a snack. And in addition to welcoming everyone here back, I am personally welcoming back my own Connecticut Multiple Myeloma Fighters Information Group members. Tonight was our regular meeting, and in lieu of our meeting, we decided this was going to be an educational program we did not want to miss. So, Dr. Joe, we're going to go back to you now live. And what are we going to talk about next, Dr. Joe? I think it might be maintenance.
That it is. And I want to give a special shout out to that Connecticut group, your fighters. I love the way that people can fight myeloma as myeloma warriors, but they're also information gatherers, I understand. So hopefully we provide some good information to them. And we're diving into maintenance therapy. So let's just take a minute that we're going to think a little bit about what is maintenance therapy and even what is before maintenance therapy, what we sometimes call consolidation. And then I'll just talk about what we typically do for maintenance and how the field is changing. So we talked a bit about this earlier, but just so we're on the same page, the words we use in general chemotherapy are induction, consolidation, and maintenance. What do we mean by that? Induction is to induce a remission. That's usually an intense treatment that's short. Like in myeloma, it's 4 to 6 cycles maybe of, let's say, DVRD or ESA-VRD, and we get the disease down. Consolidation is more intense and meant to deepen that remission. So sometimes we consolidate with a transplant. Sometimes we consolidate with a few more cycles of the treatment we had. And then we get into what's called maintenance, which is the idea here is to maintain, I know it sounds simple, but it's maintaining the remission that has already been had. And now the emphasis is not so much on getting a deeper response, although that's part of it. It's more on maintaining the response for a long period of time. That's why we want to look at how long does someone stay in remission with maintenance? How long do they stay alive with maintenance? And so when we think of what's ideal in maintenance, it's going to deepen that response. It's going to prolong the remission. It's going to be easy to administer, and it's going to have less toxicity. Because it's one thing for Kevin in his clinic to say, look, we're going to do this bone marrow transplant or stem cell transplant. It's going to be a bit of a rough ride, but it's only a couple of months long. As opposed to me saying, we might have you on maintenance therapy for 5 years. Well, I don't want it to be a rough 5 years. We want it to have it a bit easier to tolerate. And so typically our standard maintenance protocol for lots of different reasons has been lenalidomide or Revlimid that we give daily, typically 3 weeks on, 1 week off. And this was based on a whole series of studies. And I don't want to bore you at length with all the details of these studies, because I could go through the design and show we did this thing called a meta-analysis. We squeezed it all together. I've just tried to summarize it right here. That with 3 different big trials of over 1,200 patients, we saw that what's called progression-free survival, so basically how long someone stayed in remission with Revlimid, was about 52 months. When people got nothing, it was 24 months. So you went from 2 years to 4.5 years when you go on to maintenance Revlimid. That's maybe the most important thing I can say here. But not only that, it actually affected overall survival, that the overall survival was longer when you were on Revlimid maintenance. That being said, almost a third of people had to come off maintenance because of side effects. And there is a slight increased risk of so-called second primary malignancies or a second cancer. That's a whole separate topic I don't have a lot of time to get into today, but that has led to why we use lenalidomide maintenance. And then more recently, our British colleagues did a similar study and further confirmed that, as remember we said, higher on the curve is better. When compared to observation or no maintenance at all, there was no doubt that maintenance lenalidomide made a big difference. So the question is, can we do better than just lenalidomide alone? And so there was a study called the Forte study a few years ago, which again, I know it's kind of complicated here, but just go right to the very end. There's R at the top, which is Revlimid, and there's KR or Kyprolis and Revlimid as the other maintenance strategy. And so this study, if again, look at the right, compared giving 2 drugs versus 1 drug, and no surprise, 2 drugs was better than 1. And what was interesting on the next study is that although we think sometimes we always have to use 2 drugs in the high-risk patient and maybe not so much in the standard risk patient, we found the benefit of giving 2 drugs over 1 drug was seen across the board, whether someone had standard risk, high risk, or even that ultra high risk, or sometimes called double hit myeloma. So this started to set the stage for us to say, well, maybe dual maintenance is better. Not everybody believed it yet, and we need more evidence, but it's opening further doors to say, well, can I add something else to lenalidomide? We've shown it with carfilzomib or Kyprolis, but can we do it with bortezomib, with ixazomib, with daratumumab, or others? And now there's a lot of interest in giving it with daratumumab because of all the drugs that we use up front now, we often use daratumumab with it. There was one study called the Cassiopeia study that, again, I won't get into too much detail, but didn't show a lot of benefit of maintenance daratumumab if someone had had daratumumab already, but we knew that there were some flaws in that design. And so what we really wanted to wait for was this Perseus study. You may remember this because I showed this briefly when we talked about the 4 drugs being superior to the 3 drugs. And what's important in this group is, now, in the earlier part of the talk today, we focused on the early part of this design. Let's look at the later part of this design. So the standard arm, as it were, just got Revlimid maintenance. But here they had this interesting design that said, for those who in the treatment arm or in the 4-drug arm, they would get daratumumab or Darzalex plus Revlimid for up to 2 years. But if they got into MRD negativity, they could drop just back down to Revlimid alone, essentially. And when doing that, they saw some benefit with that. If you look at the right, that there were more people that got into MRD negativity and that actually stayed in it. So if you look at the bottom paragraph here, it says during DR maintenance, more people got into MRD negativity. And people, about 64%, almost 2/3 of patients had sustained MRD negativity. So there may be an opportunity here for us to even upgrade what we know is very effective in Revlimid alone by adding something to it. And then just 2 weeks ago at our International Myeloma Society meeting, there was an interesting study that was presented, the Auriga trial, which was adding daratumumab to Revlimid versus Revlimid alone. Although I have to say the big challenge here is this was only for patients that had never had daratumumab before. So it's hard to apply in our current world where we're using a lot of daratumumab, but nonetheless, they showed that getting that daratumumab plus Revlimid really did have more patients go into MRD negativity than just from Revlimid alone. So it's hard to piece this all together because they obviously noted that if people didn't have daratumumab up front, it was a benefit. But how long should maintenance therapy last? Well, we go back to our British colleagues, and they just did this analysis where they did what we call a landmark analysis, where they said, okay, was lenalidomide Revlimid maintenance good for only 2 years, or for 3 years, for 4 years, for 5 years? And I won't get into the complexity of how they did the study, but the short version was that even out to 4 to 5 years, there was still a benefit of patients being on lenalidomide. So for right now, we're typically saying that patients should be on lenalidomide maintenance for at least 3, if not 4 to 5 years. I had this exact conversation with a patient today whose original doctor told her that she only needed 2 years. But I said, with updated data, it does look like the longer someone stays on it, the better they can do. So I conclude with the common questions that we get asked in maintenance. Should someone get maintenance after transplant? Yes. What should we give? Well, at least lenalidomide, but we may be adding daratumumab soon and other options. We probably should give it until someone's disease wakes up, if not up to 5 years. And if someone has high risk, we may want to add something from the very start, whether it's a proteasome inhibitor like Kyprolis or Velcade or daratumumab, as we've said before. And right now, should we use MRD to guide how long someone's on maintenance? We're not sure yet. Outside of a clinical trial, we think that's a little bit early. And then what about this whole issue of a second cancer? Well, it's a challenging topic in myeloma because we know that all myeloma patients are at risk of getting a second cancer. About 5% of myeloma patients will have a second cancer. Being on lenalidomide maintenance may increase that slightly, but that has to be balanced with the benefit, even the overall survival benefit we're seeing with lenalidomide. So I'll stop there. We're actually right on time for maintenance therapy. Still some questions to be answered, but hopefully that gives us some insight. Rob, I'll turn it back to you if you have any other comments before we dive into our last talk.
I know, I think we're doing really well, Dr. Joe, and I'm already liking the questions coming in.
Awesome. Okay. Well, hopefully I'm seeing them too. Hopefully I can kind of answer some of them preemptively, but we'll see as we go through. So now we've come to the last lecture. I'd like to introduce myself, Dr. Joe. You've heard me so many times today. I apologize. But let's talk a little bit about relapse therapy, because chances are of the what appears to be several hundred people with us today, the majority have had some treatment before and may be facing relapse therapy. So we'll just talk about how we approach relapse therapy and how important it is what we do early on. We'll talk about the major options that we have, and then we'll end with some of the new exciting things that we have here in CAR T-cell therapy and bispecifics, as we've already indicated. This is an interesting curve, but I show this for a couple of reasons. So what this arrow is trying to tell us is that, unfortunately, with each line of therapy, now you all know what lines of therapy are because you listened to the answer to the question earlier. Unfortunately, there are fewer patients being treated because some patients sadly die. Some patients do not want to continue treatment. And so we know that it is really important what we do up front, because it has that downstream effect. And that's why I said one of our principles of frontline therapy was not to save the best for last. But then how do you choose between all these things? You know, we've been showing that slide a couple of times now, the one that makes Robin happy with all the different drug names on it. I mean, it's great that we have those options, but how do we make those decisions? Well, the one way I like to put it is it's not an algorithm anymore. We don't just say, this is what we do first, this is what we do second, this is what we do third. We prefer to say, here are the guidelines around early relapse and late relapse, but it really depends on many other factors. Most importantly, what the patient wants and what matches the patient. So it's like saying you've got this big Cheesecake Factory menu of options. If you've ever been there, there's like way too many options for dinner. So how do you choose between them? You've got to match what you're feeling like that day, what you prefer to eat, what you don't want to eat. And similarly here, we do that. A few principles I like to highlight. We've already said already, the depth of response matters. We want to choose a regimen that's going to give us a deep response. We have to respect that there are some patients that have higher risk myeloma and may require more aggressive treatment. As I said earlier, we have to balance efficacy and toxicity. It's one thing to say you're going to be sick for a short time. If it's long-term, we really have to make sure we reduce those side effects. And then importantly, because why does myeloma keep coming back? It keeps coming back because sadly it's smart and it figures out the drugs that it's on and develops a way to grow despite those drugs. And that's what we call drug resistance. And so what we want to do is come at myeloma a different way, right? I sometimes use the analogy that you're trying to get into a house and you just keep walking through the front door and then the front door gets locked. Well, we've got to find another way to get into myeloma. So we start using the side door, and then myeloma figures that out and locks the side door. So then we got to go in the back door or the attic, the roof, or whatever way it is. We want different ways of getting to myeloma. And that's why it's important to not just stay on the same treatment and add something to it, but to actually change the mechanism of action. So some of the definitions, just in case you're not familiar with these words, relapse means it's come back. Refractory means it's growing while you're on something. Progression is the word that we use. I know sometimes you think progress is a good thing, but progression is a bad thing, because we typically say progression means the disease has grown, it has developed, it has grown in such a way that it requires a different treatment. And then, of course, we've already answered the question of a line of therapy. So when I look at this big list of options that I have, I try to focus on matching that to these three things. The disease itself, is it high risk? Is it standard risk? How fast is it growing? What is the nature of that disease? The treatment, what did the patient have before and what are they resistant to? What toxicities did they have? What way do they prefer getting their route of administration, oral versus IV versus sub-Q? And then very patient-related things. What comorbidities do the patient have? What is their preference? What are their goals of therapy, right? Some say, Doc, I want to be able to play with my grandchildren. This is my primary event and activity. Let's figure out a strategy that allows that. And so we always want to listen to our patients as we have that discussion. But as Kevin and I have kind of both said today in different contexts, myeloma is not the same disease in every patient. I wish it were always like this green line, where I give the treatment, someone goes into remission, and they stay there a long time, and there's a very slow relapse. More people are like this blue line, where it starts to relapse after a long time, but then unfortunately it starts to relapse more quickly, a little bit like that questioner, that person with the question asked us about CAR T. And then sadly, sometimes we see this red line, where it can be very aggressive and and be very difficult to manage. And so recognizing that myeloma is different in every patient becomes really important. But what are some of these principles? Well, therapies change over time. And so clinical trials makes this possible. I saw that there's a question about clinical trials, and I'll make some more comments about clinical trials at the end. But we want to normalize trials. We want to make sure that people understand that this isn't just some weird experimental therapy and you're becoming a guinea pig. Kevin and I are going to have a little fireside chat in Thursday in Richmond to talk about clinical trials and try and demystify them a little bit. And one of the things we need to see is that this is actually part of our regular work. And this is what's important if we're going to continue to move the field forward as we are. Survival changes over time as new therapies emerge. So we've actually done much better as these new treatments that have come through clinical trials have actually had people live longer. And if one therapy doesn't work well, it doesn't mean another won't. So sometimes there are just certain drugs that don't work in someone's myeloma. That doesn't mean, oh no, I can't get treated at all. My myeloma is never going to be treated. We have some people that may not respond well to one treatment, but really respond well to another treatment. In terms of, and we already talked a little bit about the sort of statistics side of things, but terms like overall survival and progression-free survival, they refer to a probability for groups of people. They don't seal the fate of an individual. So if we say the average survival of myeloma is 10 years, it doesn't mean you're going to live 10 years. Sadly, what that means is by 10-year mark, half people have died and half the people are still alive. So there's a huge spectrum across that, and I think it's just important to capture that. At any given point in time, there may not be the right answer. It's hard to know. We make as educated a guess, if you will, as possible, but it's hard to be absolutely concrete with these different approaches. And so as we look at these pillars, and Kevin showed a slide like this, I've shown a slide like this, it's impossible in a short, 20-minute talk or 30-minute talk to go over all of these drugs. But it's just exciting to me that we have more classes of drugs and more ways to get at myeloma than we've ever had before. In particular, I'd like to focus on the immunotherapy part of things. So working from on the left side, I described CAR T-cell therapy earlier. We can take T-cells out of a patient, manufacture them, and give them back to attack their myeloma. We've talked already about a lot of the drugs we've been using for years that are called monoclonal antibodies. So these are drugs that hook on to one part of the myeloma cell and trigger the immune system to destroy it. More recently, we have something called antibody drug conjugates. There's one in particular called belantamab or Blenrep that was approved by the FDA. It was withdrawn for various reasons and is almost definitely going to come back to the clinic in 2025. And it's interesting because it's kind of like the monoclonal antibody in that it hooks onto the myeloma cell, but then it kind of has what I call a backpack, a toxin backpack that it drops into the cell, and that helps destroy the cell. And that's a very interesting approach because we can just give it to patients straight without having to collect their own T cells or anything, and can be very effective. And then later, I'll be sharing with you a little bit more what we call bispecific T cell engagers or bispecific antibodies, or sometimes called T cell engagers. These all have the same principle at the bottom right-hand side of the cell, and they're called bi because they have two arms. So they kind of work like CAR T-cell therapy in that one arm grabs onto the myeloma cell, but instead of us giving them back their own T cells, this drug actually reaches in while it's in the patient, while it's grabbing onto the myeloma, it also attracts a local T cell and engages that T cell to destroy the myeloma. So we don't have to go the whole process of collecting the T cells and manufacturing and giving them back. We just give this drug to a patient that we take right off the shelf, and it goes straight in there and engages a patient's own T cells. and we'll be talking a bit more with those. I'm not going to focus on the other two because that's a little bit more futuristic that we're still doing research on. So to go through the drugs that we've mentioned that we have, those naked or monoclonal antibodies, as they're called, the ones we have are Darzalex, Sarclisa, and Implicity. The antibody drug conjugate I mentioned is called belantamab mafodotin, or Blenrep, the one that's got that backpack of toxin that it can drop into the cell. And so it gives us a question, is belantamab coming back? Well, we think it will be, because we had a clinical trial here where belantamab was added to Velcade and dexamethasone and compared to daratumumab. And amazingly, we saw it perform so well that you can see the difference between the red and the blue lines here. I won't get into the details, but enough to say that it was very, very effective. In fact, there was a second study comparing it with pomalidomide dexamethasone to Velcade pomalidomide dexamethasone, and again showed a benefit. So this wasn't like a 3 versus 4 drug combination we sometimes see, or 3 versus 2 drug. It was 3 versus 3. And in both of those contexts, the belantamab did really well. So I think most of us are quite convinced that belantamab or Blenrep is going to come back to the clinic. It's probably going to come back next year. Then these bispecific antibodies, and again, this is a bit of a clearer picture. You've got this drug here in the middle. It has 2 arms. One arm grabs onto the yellow myeloma cell, and specifically in this picture, grabs onto something called BCMA, or B cell maturation antigen, which is on the surface of the myeloma cell, and a local T cell, and engages that T cell to destroy the myeloma. And we actually now have 3 different approved bispecific antibodies. Teclistamab and elranatamab target the BCMA on the myeloma cell, and we have another one called talquetamab that targets a different antigen on the T cell called GPRC5D. And then lastly, as I shared with you, the CAR T cell concept, where we actually manufacture this T cell that we've taken from a patient. Now it's got that chimeric antigen receptor on the outside, that CAR, as we call it. Sometimes we call them CARs for short, to destroy the myeloma cell. And we have 2 versions of it. They both target BCMA. One's called ide-cel or Abecma, and the other is called cilta-cel or Carvykti. So when we think of relapse, then, how do I put all these drugs together? Well, in the early relapse setting, up until recently, we were pretty much giving combinations of daratumumab or isatuximab with either carfilzomib or pomalidomide, basically. But then that started to improve as we had more options. We discovered selinexor and learned that we could give it with bortezomib. And then this just in, as I've just said, that now we have actually the opportunity of giving CAR T cell therapy earlier. So as of April, Carvykti or cilta-cel can be given as early as first relapse, and ide-cel or Abecma can be given as early as second relapse. This is one of the proposed algorithms that came from my former colleagues at the Mayo Clinic that looked at it. And I know there's lots of words and letters here, but the bottom line is that we have a lot of choice for patients. Sometimes it might involve giving CAR T. Sometimes it might involve giving a triplet. Those are most commonly what we give, a 3-drug combination, because we've had so many clinical trials that have shown to us that 3 drugs typically work better than 2 drugs. In that early relapse setting, one of the reasons why those 2 CAR Ts just got approved were based on these 2 trials, where in this case, in patients who had had 2 to 4 prior lines of therapy, getting CAR T gave on average a remission of about a little over a year, where it was only 4 months when we gave the more common triplets. Similarly with Carvykti, this was a little bit earlier, even at 1 to 3 prior lines, where the standard of care, the triplets, gave about a year, but here we got over 2 years with Carvykti. So super impressive results. We don't have anything else in early relapse that gives this kind of response, and we're likely going to be using more CAR T cell therapy earlier. So as you look over the evolution of myeloma over time, not that these earlier drugs are not effective, pomalidomide, carfilzomib, or Kyprolis, Darzalex, selinexor, these were great drugs, and they worked really well. They had a response rate in people who basically had no other options of about 25 to 35%. But now that we've gotten to these bispecifics and these CAR Ts, we've doubled, if not tripled that. Now we're seeing response rates of 60, 70, 80, even almost 100% in some of these newer therapies. And so I think this is why there is a lot of optimism. Now, I always have to balance this with, this doesn't tell the whole story. You might get 90% of people responding, but there are side effects to these things. One of the very attractive features, as I'll show you in a moment, of CAR T-cell therapy is that it's kind of one and done, meaning people get the treatment and there's no ongoing therapy thereafter. But it also comes with risks. There are risks of infections, of the cytokine release syndrome that Kevin shared with us, and even some things that we frankly don't understand fully, some of these neurological features that I'll get into in just a moment. So when we look at graphs like this, it's always important to remember it doesn't tell us the whole story. It tells us the efficacy side of things, but not necessarily the safety side of things. And again, most of these therapies can be offered late in the disease course. So Kevin shared with us a little bit about this, but just to remind people, when we go through CAR T, we collect the T cells and we do that manufacturing, but you may not realize that manufacturing could take actually up to 8 weeks even for certain patients. So we're learning now, and even just learned a little bit more in Brazil last week, that it's important when we're waiting for those cells to be manufactured, we may have to give the patient so-called bridging therapy, which is to say further treatment to reduce their myeloma so that when we give those T cells back, there isn't too much myeloma there. But this whole process takes a few months by the time we collect the T cells, do the manufacturing, reinfuse it to the patient. And people can have a lot of side effects. I'm not here to scare anybody, but I'm also here to be honest that the majority of our patients do have this thing called cytokine release syndrome, which just basically means the immune system is freaking out a little bit. I know I'm offending all of my scientific colleagues, but the immune system kind of just freaks out when all this is happening. They're not used to all these T cells swimming around their system. And sometimes it's just a fever, but sometimes people's blood pressure can drop and they may have to come into the intensive care unit. People can get what we call neurotoxicities, where sometimes it's just a headache, but sometimes it can be quite severe. And so sometimes even a small percentage of our patients develop a Parkinsonian-like effect that may not be reversible. Almost everybody gets low blood counts, and that typically we can manage. There's also a significant risk of infections, and almost universally, all of our patients have to be given the antibodies or the immunoglobulins that they're not inherently making, what we call IVIG, because of that. We see the same thing with the bispecifics, and as we're developing newer ones, maybe not to the same severity, but these drugs, of course, they're not being collected like T cells and given back. We just give directly these drugs. But these same patients can have the same issues of both the immediate cytokine release syndrome and neurotoxicity, as well as the infections there afterwards. And again, as I mentioned, for some of these neurotoxicities, we don't fully understand it, but we're learning more. We're learning more about the best way to vaccinate our patients and to prevent some of these infections that are happening. And I think we're getting better at it all the time. So if you look at these two therapies that we've talked about, you know, the Abecma and the Carvykti, and now Tecvayli, as well as those others, the two other bispecific antibodies, you know, they're both highly effective. One is given once versus one given continuously, although we're giving them less frequently now. They're typically still given in an academic setting, although we hope with time to give more bispecific antibodies in the community. And there's a higher risk of cytokine release syndrome and neurotoxicities with the CAR Ts when compared to the bispecifics. So a few key points to wrap up on this section is that they're very active agents for CAR Ts and bispecifics. We know the side effects that are there. The first generation of CAR Ts are here, Abecma and Carvykti, although there's some interesting newer ones that are being developed. Sometimes we might opt to go to a bispecific because we want to get someone's disease burden down because their myeloma is growing super quickly and we don't have time to wait for CAR T. But we're still trying to sort out what is the best sequencing of this. When we look to the future, there's a lot of new things coming. We still have another half a dozen bispecifics that are being developed. Even with new targets, we've talked about BCMA, and then there was talquetamab that targeted GPRC5D. We have a third target that we don't have any approved drugs for yet, but we're working on something called FCRH5. And so we have a lot of exciting things. I'm particularly excited about kind of the next wave of CAR T as well. We have some of these newer CAR T products that seem to be very effective and very unique in the way they work. But at the same time, sometimes it's nice to have a simple oral drug. And so the cell mods are coming in the near future. These are kind of like the next generation of Revlimid and Pomalyst drugs. We have two of them right now. One's called iberdomide and one's called mezigdomide. And they're showing a lot of promise. And then there's some other small drugs. We call them small molecules, not because they're definitely not small in price, but they're small in their targets and the way they work that we sometimes use in certain patients. And again, I show this one more time. I know it's like a broken record, but it's a happy broken record to show that we just keep adding more and more as we go through. In my last few minutes, I'll close off, and we're ahead of time here, Robin, so we're going to be good for lots of time for Q&A, is clinical trials. I think, as I mentioned earlier, it's something that we want to discuss to make sure that we normalize so that people don't think it's some boutique area. It may not always be available where you're being treated, but we want to make sure we understand trials. A couple of sort of background points. Number one, we would not be where we are in myeloma if it weren't for clinical trials. Research is just so important. If not, we'd be back to the way I did my clinic 20 years ago with one or two drugs and people live maybe 2 or 3 years. We don't want that anymore. No one is expected to be a guinea pig. This is maybe the most important point. Like if you've been napping, please wake up for this next 15 seconds and then go back to napping. The concept of a clinical trial is not for you to benefit someone else, but for you to benefit you. That is really the primary objective of all our trials. Now, yes, there may be trials that are not going to benefit you. There's no doubt. But the goal is, and the desire is always to have something that's going to benefit that patient. You're not a guinea pig for someone else. We have very tight supervision and standards now, sadly, because of our somewhat terrible history, including how certain populations have been treated. We'll come to that in just a moment. And it comes to underscore one of the most important things in medicine, which is open, clear communication with your healthcare team. I can't emphasize that enough. I know this is particularly important to Kevin as well, because we have learned that when we develop that kind of open, honest relationship, it's better for the patient. I mean, it's not only better for us in the sense that we enjoy our time with our patients more. We've actually shown you develop that kind of relationship, it prolongs your survival in myeloma because it allows you to be more almost honest about your signs and symptoms, what's going on, and so that they can be attended to. So you think, why would I want to have a clinical trial? Well, every patient is unique. It has to be looked that way. We're not just trying to funnel people blindly into things. But why would I go on to a trial? Well, sometimes a clinical trial offers a drug that's new before it gets approved. And that way you can delay the standard treatment for later, because if it works, great. If it doesn't, you still can always fall back to the standard. You're contributing to the myeloma world, but as I said, not just in the future, but presently to you right there and then. Sometimes, and with some of these agents being very difficult to access even financially, sometimes it allows, and we have more and more protections now and ways to ensure that people can have access to trials and even be compensated for their travel or other things that may be involved that are not normally part of a clinical trial. But of course, that has to be balanced. Clinical trials aren't perfect. If we knew the drugs were perfect, we wouldn't need to test them. So there can be some side effects. There can be some challenges, including it may not work. When we look at so-called phases of trials, I'll keep it pretty simple here. Think of 3 major phases of trials. I do a lot of what we call phase 1 trials. This is when we have a brand new promising drug and we want to test it out. And we want to be careful. Safety is most important in a phase 1 trial. So we have to start at very low dose. So there is a concern that in some patients it may not be effective, but it still may. And we want to make sure it's safe before we move on to a phase 2 trial, where once we've arrived at a better sense of the diagnosis, or of the dose, we can then treat a larger number of patients in a phase 2 trial to really see how well does this drug work. All right, I figured out that 10 milligrams is a safe dose to give. Let's see how well 10 milligram works in 100 patients. And then phase 3 trials is when we're taking it to compare it versus the standard of care. Okay, well, the standard of care was this 3-drug combination. Now I'm going to give the 4-drug combination. and see if it adds to it. So no matter who you are on that study, you're at least getting the standard of care. You're not getting something below that standard of care. That's really, really important. But then why do so few patients participate in trials? I mean, we talk about these trials. If you look up in different ways on clinicaltrials.gov and others, there's so many trials to choose from, and yet a lot of them don't ever get accrued. People are not aware. They don't have access. There's understandably a history of distrust and fear in the medical system and research in particular. This is one of the reasons why we work so hard in our Power program to demystify trials, and why Kevin and I will have this conversation on Thursday. But also, as I'll close off in a minute, why we've partnered with Spark Cures, which has this incredibly sophisticated search engine for clinical trials, is now embedded in the IMF website of myeloma.org. So you can type in that you live in Virginia, in Richmond, and it'll give you the trials that are closest to you, or it'll give you the trials across the country based on your eligibility, based on what you may want. Some people like to travel, some people won't. There can be insurance issues. They may not be unwilling. If one physician says, "Oh no, I don't want you to go over to that other center and do trials. I just want you to be treated here." I mean, there's lots of things that can be barriers. They may not have physicians that offer them trials. They may feel disconnected from the healthcare system. These are all things we have to be symptomatic in dealing with. When it comes to diversity in trials, this is particularly important to me. As an African-American man, when I know that 20% of myeloma patients are African-American, whereas most clinical trials have less than 8% African-American representation. And it's not just that we're trying to hit some artificial number. Can I really tell my patient this drug works and this drug is safe in you when no one representative of you was on that clinical trial? So these are the things that we have to think about. The IMF is very committed to this and overcoming a lot of the barriers that have been there. We're just about to launch a new program where patients who have been on a clinical trial can share their story with others. And in particular, individuals from historically underrepresented communities can say, "Hey, this is what happened to me, and this is what I did on a trial." And sometimes it's great, sometimes it's not so great, but it's important to have that conversation, that discussion. So as I mentioned, we have lots of resources to help people. People can just call the info line if they want, but we have just now launched this Spark Cures as of just a few weeks ago. I'm very excited about it. Our friends at Spark Cures are disturbingly nice and very smart people, and they have found a way to really help people. And you can go in anonymously if you prefer not to share any information, but if you want to share more information, I've had 2 prior lines of therapy, or I've had this and I haven't had that, it can help narrow the search a little bit and guide you in your effort as you seek to obtain a clinical trial. So with that, Robin, I'll turn it back to you, and we can get going on the Q&A pretty soon. And it looks like, believe it or not, we are right on time.
We certainly are. And I think, Dr. Joe, there you go. I was just going to say, you and everyone else here, grab a sip of water. Water is our friend, especially for myeloma patients, right, Kevin? Flush those kidneys. It's just good for us. And after talking for all the time you've talked, Dr. Joe, I'm glad to see you taking care of yourself as well.
Thank you.
And this gives us a little bit of time to ask people, if you haven't put your question in there, we have quite a few good questions coming in. And I would say, Kevin and Dr. Joe, if you are ready, let's begin the Q&A.
All right, giddy up. Well, we stopped at question 20, so why don't we pick it up from question 21? And we're up to almost 40 questions already, so we'll try and keep it as we've been doing, Kevin. Appreciate so much your succinct nature. You have an uncanny way of saying complete things in short sentences. Amazing. So question 21, what is the optimal dose of Revlimid in the maintenance phase when there is only drug given during this phase? We really have to kind of go back to what the clinical trials were. The majority, as I showed on that slide, the majority were 10 or 15 milligrams, 3 weeks on, 1 week off. Some of the trials gave it continuously. Most of us give it 3 weeks on, 1 week off. But that's typically the dose that we give. And it's partly because it's a dose that is maybe better tolerated than 25, but also still has sufficient efficacy to benefit the patient. Here's another question. Why is treating light chain myeloma more difficult than treating other forms of myeloma? And does the research you've presented include light chain myeloma patients? I'll quickly answer this. We'll say, it's only a little bit more difficult to treat for two reasons, essentially. One, light chain myeloma can tend to be more damaging to the kidney, and so we have to be a bit careful there. And sometimes it's a little bit more delayed in getting the first diagnosis, because sometimes people don't look for the light chains, they only look for the heavy chains when they do that initial testing. But yes, all the studies we're referring to now almost exclusively, almost always include light chain myeloma patients. There was a day many years ago when we didn't have as good light chain testing that some light chain patients were not eligible for certain trials, in particular phase 3 trials. But that's really changed now as patients are having better testing for it. Question 23, Robin, could you please remind people how to access the recording and the slides? People are asking.
Well, if people are asking, then we're happy to share. So go to myeloma.org. At the top of the page, you'll see a little button that says videos. Click on the videos. And this program is a regional community workshop. You can click there, and that's where you'll find it. I would say for the next week, this will also be right on the front page of myeloma.org, so really easy to find. So the front page is just like your newspaper, and what's fresh and new is on the front page. And then after a while, that's where you click on the videos and go to regional community workshops, and then you'll find it there.
Great, thank you. Kevin, I'll ask you this one. Are bispecifics available in the community oncology setting?
Loaded question. And I think that, for one thing, depends upon where you live. And then secondly, the challenge of the bispecifics is they all come, unfortunately, saddled with a REMS program, which is a risk evaluation and mitigation strategy program. And it takes a special certification for not only the physician, but the providers, the pharmacy, and the actual health setting to actually get involved in the REMS program. And so sometimes that can be the challenge, especially in a community oncology setting where myeloma is not the major cancer that's being treated, but rather solid tumors. And so sometimes that becomes a challenge. In our area in Richmond, within 50 miles, we have no community oncology settings which give the bispecifics. And so we do it all here, but I think that may change. But I really do believe the big lesion is the REMS certification.
Yeah, no, I think that you put it really well. I'm also optimistic like yourself. I think even the next wave of biospecifics we have that are going to likely have less cytokine release syndrome. And now as we've learned how to use them a bit better, we may be able to give them more easily in the community. But most places in the country are still going to the academic setting, at least for the first several cycles, and then maybe decant and go into the community. Here's a question. Do you personally know high-risk patients who have lived 10 years or more? Absolutely. It may not be the norm, to be totally blunt and honest, but it's always a balance. And, we do have a high-risk myeloma support group, as Robin mentioned to us at the start, and I had the privilege of being there for their very first meeting. And we want to be careful that we want to balance, as I always say, optimism and realism. That high-risk status doesn't always behave, if you will, as high-risk status, meaning I sometimes use the analogy, it's not perfect, but, if you're out on the highway and you see a red Corvette, chances are it's speeding. No disrespect to our Corvette drivers, but chances are it's speeding, but it may not be, right? It's got the engine and is designed to go quickly. So some people may have so-called high risk by their cytogenetics or something, but they may not fully behave that way. And so sometimes we can control the disease well. And as we're developing these new drugs, the difference between standard risk and high risk in terms of outcomes is really getting narrower. I think we're catching up a lot of that difference. Currently MRD positive on Dara-Dex maintenance. Should a third drug be added to convert to MRD negative? Such a great question. Again, I think the simple answer is right now we don't have the evidence for that. That's the sort of thing that we're studying in a clinical trial to sort out. MRD negativity is a general good goal, but it's not necessarily in every patient. And we want to be careful that we don't end up giving people unnecessary extra drugs or toxicities that may come with it if it's not necessarily going to affect the long term. Here's a great question. Can you talk about clinical trials? Do they put you in danger, i.e. replacing a therapy you might need but suspend for the trial, not knowing what or if you're getting something? Sorry, I don't understand quite the importance for the patient, but more for science, so to speak. Kevin, do you want to first address that? I mean, I talked a little bit about it, but it'd be nice maybe to get a second opinion or a second approach.
Yeah, I think you did a great job explaining that. But the one thing I always tell patients is that you will never get less than the standard of care. So you always get the optimal treatment. And so usually in a clinical trial, then we are adding something to what would be the standard of care. If it's going to be a randomized clinical trial, you may get a placebo, but you will always get the best treatment available, and with or without perhaps the study drug. In some situations, and this was, I think, kind of alluded to in another question, is why don't we get all these new drugs up front? Why do we always get them later? And that's simply because again, that's that standard of care. We don't try new drugs in patients, untested drugs in patients who have really, really good options up front. That would be the standard of care. And so that would put patients at risk.
I think you've answered that beautifully. I very little to add to that. I think it's just so careful. And it goes back to that conversation with the healthcare team, right? Building that trust, going through the details, understanding the principles behind it. What are the options? I'm not saying that every patient, every time they come to have a new treatment, has to be on a trial, by no means. But it should be part of the discussion. So thank you for answering that. I am in Canada, Toronto, a city I used to live in. So hello, shout out to my Canadian peeps. I am on KCD, Kyprolis cyclophosphamide dex, a very Canadian regimen. I am high risk, aggressive IgG kappa. Is there a maintenance for this type of line? I am under the impression I take it until it doesn't work anymore. I'm on weekly treatments. So yes, I mean, typically the word maintenance we use for after a transplant, but I think I understand the essence of your question about sort of the continuous treatment. So for something like KCD, where we're giving the Kyprolis or the carfilzomib, a lot of our protocols that we build with carfilzomib start on a weekly basis, but there may be an opportunity to have that reduced to every other week. So typically Kyprolis is given 3 weeks on, 1 week off. So in any given 4 weeks, you're getting it for 3 out of those 4 weeks. But what we're starting to do for a lot of these patients after they've been on the drug for at least 6 months or maybe even a year, assuming they've responded, we may drop that middle week. So they may just get the drugs on week 1 and week 3, as it were. So basically it's every other week. And it's amazing. That does have an impact very much on frequency of going to clinic and so on. But in general, high risk or not high risk, but particular in the high risk setting that you've described here, we would give that ongoing treatment, maybe with the reduction of frequency of Kyprolis, of course, but we would give that until the disease breaks through. Kevin, are light chain only disease patients without an M spike eligible for stem cell transplants?
Absolutely, they're eligible for stem cell transplants. So yeah, there's just because you have light chain disease, doesn't mean we are going to treat you any differently.
Hear, hear. Does newly diagnosed myeloma patient mean they were literally just diagnosed, or can it be someone who's been diagnosed a while ago but is treatment naive? So great question. So yes, when there are patients that can be diagnosed, let's say with smoldering myeloma, where it doesn't immediately require treatment and they've not yet received treatment. So their first treatment would be under the umbrella, if you will, of newly diagnosed or a frontline therapy. Just an added comment on that, because I didn't have as much time to get into it on the smoldering side. There is a lot still to be learned about whether or not we should be treating smoldering or when we should intervene. There's a strong movement in the cancer world in general of catching disease early and intervening, which of course is so important. But we also want to make sure we don't treat too early. Remember when I showed that spectrum with MGUS? I mean, we probably don't want to be treating 5% of people over the age of 40, especially if the treatment may be toxic, and if without that treatment, they're going to do well. Most people with MGUS will never develop myeloma. So we want to be smart about when we intervene. Please explain the difference between non-secretory and oligosecretory. So the short answer here is that we have some typical minimum cutoffs for M spikes and light chains. And in the US units, it's typically an M spike of 0.5, sometimes even of 1.0, and of light chains of 10 grams per deciliter. Sometimes people have a little bit less than that. They have some, but not quite that minimum standard. That's oligosecretory. True non-secretory means we can't measure the myeloma at all in the blood or the urine, meaning the light chains, the M spike, whether it's M spike or light chains in the urine, cannot be detected. So in those patients, we either have to follow their bone marrows, or sometimes we can follow their imagery, their imaging with a PET scan or a CT scan or an MRI, because they may have so-called extramedullary disease or something that we can follow thereafter. I'm on Pomalyst and Dara for maintenance. Are there major differences between Revlimid and Pomalyst in terms of staying in remission? Kevin, do you want to take a stab at that?
Yeah, well, generally most patients who are on Pomalyst have are refractory or have relapsed while on Revlimid, and so that's the situation where you're generally on Pomalyst. So in that situation, to go back on Revlimid for maintenance obviously wouldn't work. So in terms of being on this combination, yeah, I would have to say that's what you want to stay on. You don't want to go back to Revlimid, if that's the gist of the question.
Yeah, no, I think that's well said. I mean, it's tough. I had the privilege of being involved in Pomalyst's development back in the day, and there are some, as you mentioned, strong similarities to it in Revlimid, but interestingly, it can overcome Revlimid resistance, and that's why it's thrived as another drug. In maintenance, is Dara every other month for 2 years as effective as every month? The doctor said there was no difference in the study, so I chose every other month. I mean, those are questions that we don't fully have the answer yet. Like in the Cassiopeia study, it was given every other month, and it maybe wasn't as effective. But if it's being given with something else, or if there hadn't been Dara before, and there's lots of different ways of looking at this. I think it goes back to the concept of maintenance, which is it's not so much giving a lot of treatment as much as maintaining the remission that's there. And so I think if that's what you've worked out with your physician, it's hard for us to comment on specific cases here without knowing the full context, but I would have that conversation with them. But we're still learning about the optimal way of giving daratumumab maintenance. It might be the easiest way for me to say that. If bispecific target different mutations, why not give more than one at a time? Fancy, you should ask that question, because there is a clinical trial that was just presented last week in Brazil, and it's previously been presented where actually we do that, where teclistamab and talquetamab, so teclistamab that targets BCMA and talquetamab that targets GPRC5D, are actually given together. Not to mention that we're doing research on so-called tri-specific drugs. So tri-specifics are drugs that actually have 3 arms. I don't have a third arm, so I can't quite add it here. I guess I could maybe put my knee up here and give you a third arm, but where 2 arms grab onto the myeloma cell and the third arm grabs onto the T cell. I think we're going to understand that better with time, but it's a great question because it makes me feel good that you understand the principle and the concept enough to ask what's already being done in research. I think a lot of people don't participate in clinical trials because it's presented right in the very beginning when they are, as I was, scared to death. And thanks for adding your name here, Lori. That was very kind of you. And I appreciate the sentiment here. Myeloma can be very scary. I mean, it's one of the reasons why we host these meetings, so that we can try to demystify it a little bit, but it also doesn't take away some of the sting. And I agree with you that it may not be presented at the right time in the right way. which is why obviously that development of a relationship, as we've said so many times, becomes so important. I appreciate that myeloma is scary. I also appreciate that we're trying to do everything we can. I think of how hard Robin and her whole team works in supporting these support groups. Robin shared with us the new chatbot that we have, Milo. And Milo even has an emotional component, that I've had people talk about discussing with Milo their concern, their worry, their fear, them being scared. And it's been very interesting to see how the chatbot has responded. So feel free to go to myeloma.org and as soon as you pull it up, there's that chatbot right in the corner, little area where you can start asking it questions. And I hope that can be helpful to you. But I really do appreciate that comment, Lori. It's very, very helpful. Let's move to question 37. After CAR T, when is bone marrow biopsy recommended? Do you also track M-spike and other myeloma indicators? What do you think there, Kevin?
Absolutely. We track after CAR T just as we would after any other therapy. So we always track those myeloma markers. I don't know there's an absolute standard on when to do the bone marrow biopsies, but we will, in our institution, we definitely do them after 3 months, 6 months, and then a year, and then we go out after that. Again, dependent upon what those markers show.
Absolutely. Completely agree. With that, I don't think there's a perfect standard, but often is guided by what the blood counts look like. And sometimes we may have to do an extra marrow if the blood counts are staying low for longer, because sometimes we may even have to give more stem cells back to the patient. Is there evidence of neuropathy as a side effect for long-term Revlimid maintenance, Kevin?
Absolutely, yeah. Revlimid had one of its early side effects that was known for many years ago, 2005, that it causes neuropathy. And so long-term use, again, one of those potential long-term side effects among others.
Well said. Here's another good question that says, if it helps the previous questioner, I received my step up of the bispecific Talvey or talquetamab and have since been getting my follow-up bi-weekly treatments at my local cancer center as my healthcare team are fabulous and got trained to administer the drug. I love that. So thank you for sharing that with us. That deserves a little clap there, Robin. Thank you. Because that's really the ultimate goal, is to provide drugs where people are. And if that can be close to them, especially after those first few cycles, the risk of cytokine release syndrome and other things are much lower. So that's great. I think your healthcare team is fabulous, whoever wrote that statement. Why are some patients receiving teclistamab every 2 months without restarting step-up dosing? Wow, great question. I answer the question this way. There is really no drug in myeloma that we give today the exact way it was first introduced. And that's because as we use these tools over and over and get more comfortable with them, we start to learn what works, what doesn't work, what's the optimal way and the suboptimal way of working with them. I think we're still figuring that out with these bispecifics. When teclistamab, if you look carefully at the label, it says it's given every week. Well, I don't know any major myeloma center that is still giving it every single week. We've learned with time we can go less frequently. So we keep every week, it comes with more side effects and more challenges. So that's why there's some who are dose reducing after, I don't know what you're doing in your center, Kevin, but for us, for example, somewhere between week 8 and week 12, we often drop down to every other week. And typically at 6 months, we drop down even to once a month. What we don't know yet is should we actually fully be stopping either. So I don't know if you're taking a similar approach to that, but that's how we've done it.
Yeah, we definitely drop down as soon as possible. And really, it's based upon response as much as anything. So.
Right. And I think in answer to the second half of the question, which was, do we go back to step-up dosing? We've typically found as long as someone has been receiving the drug on a semi-regular basis, even if that's once a month often, then we've been able to go back to, or we've been able to continue it without having to redo the step-up dosing. We're coming down to almost our last question. Look at our timing here, Robin. I'm so happy. Are there clinical trials for smoldering myeloma? Well, there's a leading question. The answer is absolutely yes. and you will be hearing a lot more about this in the coming few months. So we know that one of the most important meetings we have in myeloma, in the world myeloma community, is ASH, American Society of Hematology. I have the privilege of serving on the ASH executive, and we're getting ready and prepared for this huge meeting that happens every December. This year, we're going to be back in San Diego, and we're always happy with that because typically San Diego brings us sunshine. And I've just had the privilege, and I can't go into the details, but of reviewing all of the abstracts that have been submitted to ASH. We had a record number of submissions this year, over 8,500 of total abstracts, over 1,500 for myeloma. It's just mind-boggling. But in answer to your direct question, yes, there are lots of studies going on in smoldering myeloma. Whether we should treat or not treat, should we give one drug, should we give two drugs? When do we characterize the treatment? Meaning, smoldering myeloma is also a spectrum of itself. We have now what we sometimes call low risk, intermediate risk, and high risk. So lots of studies are going on there. And I think we're going to see a lot of exciting data over this next year in myeloma in general, and in particular in smoldering myeloma. And with that, Robin, we've gotten through the over 40 questions we've received, and I will turn it back to you to wrap us up.
Well, this is amazing. I'm applauding you both. It was a lot of really, really good information. And no matter where people are in their myeloma journeys, they had to have learned something tonight, and that's a good thing. And that's a goal for us each and every time we talk with patients and care partners. We want them to go back home with hope, with being reinvigorated with knowledge and education, and feeling like there are lots of good things happening in our myeloma world. And talking about ASH with clinical trials, again, trials are our future. And so pay attention to these trials. Who knows, maybe next year one will be FDA approved and just right for you. So speaking of education, it doesn't just end here. It just never ends because there's so much happening in the world of myeloma. So we have a few more workshops going on, and Dr. Joe and Kevin are going to be in Virginia on October 10th, and that's going to be a fantastic program. So anyone who's in the area, that is an in-person program, please, you can register for that online on myeloma.org and learn a little bit more. As far as the next webinar, I'm particularly excited about this one. It's on nutrition, but check out this title. It's Harmonizing Nutrition and Novel Therapies. So we have one of our Nurse Leadership Board members, Donna Catamero, paired with a nutritionist talking about how important nutrition plays and has an impact on not just myeloma patients' lives, but everyone's life. And then next, which is another really important one, in person, we're going to be back in Kansas City on October 19th. That's going to be at the Westin in Kansas City. And please go onto the IMF website and register for that in person. We're going to have a nice continental breakfast and a nice boxed lunch in between, and really excellent speakers for all three of these programs. So we encourage you to continue your learning. And as always, we will encourage you once more to give us your feedback so we can make sure we make adjustments, we bring you the information you need, and your voice really does matter to us. We listen. And our partners, AbbVie and Amgen and Bristol Myers Squibb, GSK, Johnson & Johnson, Karyopharm, Sanofi and Takeda, we're always so grateful to them for helping us to bring you these educational programs and opportunities. So we thank you very much, and we thank Dr. Joe, and we thank Kevin, and all of you for spending your time with us tonight. Please continue to learn, and always feel free to reach out to the IMF, whether it's Milo, the info line, or through support groups. We're all here for you.
Thanks so much, Robin.
Thanks, Robin. Thank everyone for attending.
Have a great night.
Night, everyone.